Wonderful.
Hi there.
Are you done? Okay. So good morning, everyone. Good morning, ladies and gentlemen, dear friends. Welcome to the first annual conference of the German-Israeli Health Forum for Artificial Intelligence. My name is Carsten Ovens. I'm the Executive Director of the European Leadership Network in Germany. And on behalf of all our colleagues in Germany and in Israel, it's my pleasure welcoming you, Ronny Gamzu, saying thank you already very much for hosting us here today at your hospital. And, well, we are looking forward for an amazing conference day. But let's start with some introductory remarks. And Raisa.
Hi, my name's Raisa. I run HUR Partners. It's an early stage investment firm. I've done about 15 investments over the past 5 years, specifically in health tech and silver tech. For those of you who are not familiar with silver tech, it's the aging tech economy. But my love affair with healthcare actually started about 10 years ago when I became what I call a professional patient. My eldest was born and we got stuck in the NICU for about 5 months. And that was my first experience with healthcare. And once we got out, I decided that I wanted to fix healthcare from the outside in and from the inside out. So I've been focused on the startup side and investing, but I do know that the leadership, the thought leadership in academia and in government is what is going to focus population health and improve it in a significant way when we're thinking on a social and a global scale. So I'm very excited to be here with you today.
Lovely. So, I mean, you all know that our two countries, Germany and Israel, do have a lot in common. And one thing for sure is our healthcare systems, both based on the idea of social insurance, both with a strong focus on digital transformation, very much needed in both countries, maybe in Germany still a bit more than here, so that's why we're having this conference in Israel, to get inspired, to learn. But our two countries actually complement each other. The need for innovation, the drive for innovation, also the IT competence here in Israel on the one hand, and on the other hand, large corporates, a variety of HMOs, of health insurance companies in Germany. And that's what we try to accomplish with GIHF-AI, the German-Israeli Health Forum for Artificial Intelligence. Bringing the best experts from academia, from politics, from administration, also from the industry, together from both countries. Connecting them, trying to exchange ideas, trying to learn from each other. And as you all know, and probably have seen it while you registered, we have this nice little booklet. It's just fresh out of the printer in German and English, so pick your choice. And we just produced this as a kind of very innovative brochure. It's a QR booklet. So that means inside you do find a lot of QR codes that will link you to our website. And there you do find not only this small booklet, but a 52-page booklet, which is basically the summary of, in total, I think, 9 publications GIHF-AI produced over the past 12 months. It is policy briefings on our fields of interest. It is also political recommendations and reports from the various roundtables and smaller hearings we had at the Bundestag, also here in Israel. So feel free to have a look at the little booklet and download the full brochure online at GIHF-AI.eu. All the links are inside. What else should we take into consideration today?
We have a lot to get through today, so just a few logistical things before we kick off. First of all, if everyone could silence or turn their phones off so we can give the speakers their full attention. There will be Q&A after each lecture. We have time for 1 or 2 questions, so prepare your questions ahead of time. We're going to call on you. But if we don't get to everybody's questions, please feel free to continue the conversations during the coffee breaks and during lunch.
Okay, and if you do want to use social media, I mean, we will do pictures, as you've seen, as you have been informed also beforehand via email. So if any one of you doesn't want to be online or any picture, just let us know, or our photographer. And of course, he will only use good pictures. And if you do social media yourself, feel free to use our hashtag GIHF-AI22, so we can also track you and retweet or copy and post, whatever. So
So without further ado, I would like to invite Dr. Asher Salman to the stage, Head of International Relations at the Ministry of Health, to kick off the day.
Wonderful. Enjoy the day.
Good morning, everybody. It's a pleasure being here again with you. It's actually, for me, the second time with ELNET and this very important alliance between Germany and Israel, as we have started October last year in Berlin, and I'm so happy to see you here today. I would like, of course, to thank Esti and her great team for organizing locally, and the organizer committee. I would like to dearly thank Professor Ronnie Gamzo for hosting us and being part of this important event. I would like to say that as we go ahead and we do understand how important these fields are, we are taking some approaches, many locally, and I do believe that Esti and her team are going to present it, so I'm going to leave it to you, but otherwise internationally we are taking many approaches as well. So obviously our very good and a new cooperation with Germany. At the same time, we are running a European alliance with the Baltic and Nordic countries, which we are going to meet tomorrow, and that will be again the second meeting of that. There are many initiatives now starting by the World Bank that we are part of, not only in OECD countries, but rather also in other countries around the world, where at least the understanding that a good, robust digital health system is important, crucial, not only for better clinical outcomes, as we all understand, but also for, I would say, a better economical running of the system. And in that sense, I think the most complicated thing would be not to bring the technology, but rather to bring the knowledge and the commitment and the way to train people to be part of this important world. At the same time, these days, and it's not a secret, as the President of the State of Israel announced it, we are planning to open a GDO with WHO, which would be a kind of a regional center for digital health, innovation, and genomic medicine. Hopefully that could be pushed ahead in the next few weeks, and we'll be able to open this very important establishment, hopefully at the end of 2023 or the beginning of 2024. It has to do with a very strong commitment of our government, hopefully also our new government, as well as with a very strong international commitment. As this center is not going to be an Israeli center, it would be an international center, bringing many experts, foreign experts from many countries to work with us here, and then try to create, I would say, meaningful results, meaningful tools that would be in benefit for everybody. So that is another approach that we are taking, and in that sense, we do believe that our close work with you, our German colleagues, would contribute quite a lot to this approach. So otherwise, I was talking quite a lot till now. I guess I have to leave the podium for experts. I would just say that in the coming Health Committee of OECD, which would be this week, Thursday and Friday, digital health again would be a major issue, not only in traditional ways, but also ways to understand better how could we deal with manpower lack, both doctors and nurses, and how digital health could be part of the solution as a lesson learned from COVID-19 and as a new tool in mental health, which we all understand that we have to use much better digital tools in our approach for comprehensive modern treatment for mental health. So thank you very much. Enjoy the weather here, and I hope to see you all again.
Thank you. Now it works. Okay. Toda rabba. Thank you very much, Dr. Salman. Now it's my pleasure. I already mentioned him, our host. Dr. Rani Gamzu is not only the boss in the house, so to say, He is very well known for running around the world. We had the pleasure of doing a quick run around the Spree last year, so I still owe you a run here in Tel Aviv. I tried to find you earlier today on the beach. Obviously, you were already working here, but maybe next time. Dr. Gamzu, among many other things, is also a member of the Board of Trustees of GIHF-AI. We are delighted in having 26 experts from both countries, from various fields of interest, who support our program, and he's I think it's fair to say one of the active ones. So please join me in giving him a warm applause for his keynote. Ronnie Gamzu.
Thank you so much, Carsten, and really it's a real pleasure to host you here. It's our honor, and what we are doing and looking ahead, trying to look ahead, we do understand that running a hospital, giving healthcare services inside hospital all around the world is not going to stay the same. And we are looking ahead, looking at the future and trying to bring the future to the present. And we understand our challenge. It's a huge challenge, and we want to, of course, to deliver that to many hospitals all around the world. Israel has a kind of innovatory character, and in healthcare we have to lead and to do the same. So smart hospital or smart healthcare organization, it's not only hospitals, you know, it's a very complex organization, operation daily, but the trends are, you know, not only in healthcare, in any industry, to be more technological. We have technologies all over. They are running in a huge pace. There is a revolution in any technology, and we have to meet it and to close the gaps. We have to be faster, we have to be smarter. We cannot do diagnosis or treatment or any kind of medical operation without doing it in the most smartest way, of course, smartest, accurate. We have to be more accurate than we are practicing medicine today, not only in hospitals, but even in the clinics, to be more tailored, because we know the diversity, the variety of situation. To converge sciences, we cannot go ahead and be smarter and to be more technological. We have to converge many sciences, not to stay and remain healthcare sciences, to bring the formal sciences, engineering, mathematics, statistics, anything into healthcare, and to do and to close the gap, because this was being done in other industries all around the last 30 years. Healthcare is still way beyond. We have to close the gap. We can close the gap. And the real change, the enabler, is digitalization. So taking all the data, taking all what we know about the patient, about the disease, about the possible diagnosis and treatment, taking all that into digitalization, put the data there, and then take out of the data the insight, because we are now have a lot of data. We are preserving the data, we store the data. Although it was expensive years ago, now it's less, but we have tons of data, a lot of teras. We do not take out of the data enough insights, and the insights are there in order to be better physicians, to do the medical practice better, faster, more accurate, more tailored. We have to use the data, and this is, of course, the huge challenge that is waiting for us. All we are talking about digitalization is artificial intelligence, meaning try to look into the data, try to find the patterns, try to understand that, and to bring about algorithms that will assist us to do better medicine. You know, you take any industry today, if you take transportation, if you take, of course, cyber, if you take economy, fintech, anything was revolutionized around the last 20 years. We didn't do the same, and this is the time for medical care in any healthcare organization to do the same. We are driving, we are using the ways. We know the way ahead. We know our way, but still we are using navigation system in order to maybe to take the better way, the most accurate way, the faster way. In medicine, we are not doing that enough. Physician patient encounter is more or less the same that it was 10 years ago, 15 years ago. We are seeing around 500 patients in the ER any day. The same patient that we are seeing today, such patient, the same characteristic was there, let's say, few weeks ago, few months ago. And we are not learning, we do not surface in enough insight for our physician to do decision support to what they are doing. Not only the physician, the nurses as well. And this is in our hands because it was happening and still happening in any industries. Healthcare has some kind of barriers. We have to talk about that. These are the products. There are many products in AI that are being pushed ahead. They are coming to the FDA. They are in the pipeline. We have to acknowledge them. The culture is changing. The skepticism of physicians and of the industry is now changing. They are more being embraced by our system. We have to push for that any day. And this is a kind of, you know, what is really medicine is a lot of uncertainty, a lot of gray areas. This is the right field to use AI, to use the data in order to clear our way within the uncertainty, within the probabilities, the different probabilities. So using that, physician now understands that the young physician really are open to this kind of way, and it's the most complex task, but you know, usually when they're saying, yeah, we can use AI in many other industries, but healthcare, you know, it's more complex. Healthcare is kind of a very sensitive issue. You can do mistakes. If you take, you know, autotech or autonomic cars, they are the same. They are very complex, but still we are moving ahead and using many AI systems in order to do that. So these are the barriers. You know, maybe the most important one is physician skepticism, but to be honest with you, it's changing. I see the young physicians, I see the young scientists in healthcare, even nurses, and I know that now they are embracing and taking the possibility of using AI in decision support more freely. And this is an opportunity, not only for Israel, but you know, for any country around the world. Don't stay and say that this kind of technologies will not invade healthcare. They will invade, and we will find the right patterns in order to succeed. Data structure, EMRs, resources, IRB, FDA, meaning regulatories, scalability, healthcare system are very diverse around the world. However, all these barriers, you have to understand them, you have to study them, and then confront them and succeed. Don't say, well, you know, it's not going to be scalable because we are a healthcare system that is very different from the European one and from the States. Do whatever is needed in order to adopt it, in order to make it more scalable. It will succeed. This is what I think. And we have to look into AI or to look into using algorithms, not only in the clinical care, but of course improving population health, reducing cost. You know, if you are reducing by 1 or 2 or 3% the rate of no-show in your outpatient clinics, is tons of money, tons of billions of dollars. And if you are doing planning of your slots in your operating theater, again, reducing costs. There is many waste around healthcare, not only in hospitals, but all around healthcare organizations. Use AI, use smart tools, use algorithm in order to manage your operation better. We are trying to do that daily here in this medical center, but I know that this is gradually going and scaling all around the world, patient experience as well. So AI application all around healthcare can be, of course, diagnosis and treatment. We know that we are talking about sometimes diseases, it's not one disease. If you take diabetes, it's not 1 or 2, there are dozens or hundreds of the same. and we are studying them, we know more and more, and then we are doing the personalized medicine or taking many very tailored kind of care, workflow, computer vision, taking a lot of images we are using to analyze images with our own eyes. Really, this is the way to go in the current time. No, we have to use more sophisticated image analysis. When you're seeing image, you see mathematics. There are bytes below the image. You can use that in order to diagnose better. And this is going more and more if you are analyzing graphs. I was a resident 25 years ago, I think, in the delivery room, and I was looking at the fetal heart rate. So I came to accept a woman that is during delivery, let's say 8 hours, and I had to analyze the fetal heart rate for 8 hours, and I'm doing like this in all the papers, and trying to say, well, the bit-to-bit variability looks okay, or you know what, no, and then I'm arguing with my colleagues. This is not the way to go, and still this is the same thing that they are doing today in the delivery room in this hospital. And we have to use more sophisticated algorithm in order to do better and more accurate. Okay. Let's go ahead. I will, when I'm talking about AI, some say, okay, you are doing many advances and revolution in data. It doesn't concern the real basic research. Let us continue with our basic research with genomics, proteomics, and other basics. We cannot go ahead with the advanced basic research without AI. And I'm trying to say that anyone that uses genomics, proteomics, and trying to study the map of a cell, the map of a tissue, in order to understand disease, you cannot go ahead and really succeed without using AI, digitalization, more accurate way to analyze your data. And you know what? It's not only omics, stem cell, which is a growing field, and I would say gene editing, anything that you are looking ahead and you're saying this is the real future of medicine, not the data, not the data analyst, not the wise guy that are doing algorithms. You, as a researcher, in your basic lab, the best one, you cannot go ahead in any kind of research in the next few years without somebody next to you that is an expert of data. This you have to understand. Some of them, and I see the best medical centers around the world, and they are doing expansion of labs, advanced therapies, clean laboratories, anything you can mention, proteomics, omics, total omics. They are putting a lot of resources in these machines, in these labs, but they're not putting enough in AI experts. If you take a hospital in Israel, but Israel is not just unique for that. It's in any other country. You will find many PhDs, many lab scientists, many best of, physician scientists. If you count them, you will get, dozens, maybe hundreds. But if you will count the number of AI experts in the same hospital, in the same scientific best organization, you will have, less than 10. If you have 15, you are the best medical center around your area. Why is that? Still, the culture of us is putting resources in labs, in machines, and less in data analytics. And this must change in anything that you want to, you're looking around. Bioconvergence, again, we are in silos. We are in silos of healthcare sciences. Healthcare sciences cannot go forward, cannot be promoted without linking them with the best mathematicians, statisticians, engineer person, physicists all around. Bioconverge the sciences in order to reach real innovation. So the era is disruptive technologies. Everything is going very high in any technologies around the world. Healthcare almost stayed in the same place. And we understood that all around the years, but mainly post-corona. These are the barriers. I talked about the barriers. We have a very rigid hierarchy in medicine. You know, if you take a software company, the first-year software engineer will stay over the night in order to solve some kind of a bug, some kind of a problem in the software, and he will succeed. In healthcare, if you let the first-year resident to solve something, no. The hierarchy is very rigid. He'll be kicked out of the room if he will try to suggest something. And this is, of course, anti-innovation. Fragmented system, not in Israel, but in many other places around the world, not enough R&D resources, possible harm, primum non nocere, we are trying and repeating that. Possible harm or primum non nocere is anti-innovation, is anti, you know, it's a barrier to start a new thing, to imagine a new thing, and to try to do that. Of course, we have our clinical trial concept, which is another barrier, many regulatory bodies, and limited scalability. I talked about that. This is part of the barriers, but we have to acknowledge that because we can take them away. The opportunity in Israel, but you know what, not only in Israel, many other countries around the world. This is the time of disruptive technology. Just, you know, migrate them, migrate the smart people into healthcare. We have a startup nation culture. We are giving medals for attempts, not medals for successes. This is the way to go in innovation, and mainly in order to push ahead AI and digital in healthcare. Public healthcare system, large university hospital, many other countries have that. Competitive market, still in Israel, there is a very competitive healthcare market. Centralized system gives us a very advantage in data, incentive from the government, and post-corona. Why post-corona? What corona has to deal with that? First, healthcare was in the center, the value of technology understood. We have some kind of disillusionment. We thought that healthcare is the best. Healthcare is, you know, touching the edge of technologies. We are better than other industries. Yet, corona proved to us, in order to diagnose a simple, small virus in my nasopharynx, it took hours and hours and hours, many days, sometimes days. So we need to understand, and we are all confused. Some countries were in a chaotic situation. Healthcare is not at the edge of technologies comparing to other industries. We have to acknowledge that, understand that humbly, and to push ahead in order to close the gap from other industries. And capital that seeks innovations, it was very true around 2021, not exactly in 2022, but hopefully it will change again, and capital will be pumped into healthcare. And this is another opportunity, because health high-tech and high-tech as a whole is looking for the next engine, for the next thing that will propel the high-tech industries. And the smart people just have to migrate from fintech to healthcare. This is all the same. This is data. You take the data, you change it to algorithm. You can be an engineer in Mobileye and then be the same one doing the same innovation, better, of course, saving lives in this hospital. And this is what we are trying to do daily, and to attract them into this hospital. But as a movement, as trying to redefine the future, we must do that as a system. So let me go ahead. What are, in my view, the 8 golden keys, not only for hospitals, but healthcare organization? Foster ideation. We are stuck to the textbook sometimes as physicians, as scientists in healthcare. Take away the textbook. Try to innovate. Try to think different. Redefine, reinvent, rethink. To have a legal entity in your healthcare organization that will push R&D and will do the confrontation with the industry, collaborate with the academy and the industry. We cannot do that alone. Of course, have a flexible open data strategy. We are in the crossroad. If we will be rigid in data, no healthcare or digital health company can go ahead and really succeed in innovation. We have to understand that we have a moral obligation in order to push ahead digital innovation within our country. Expedite IRB approval, hub for innovation. We have a hub for innovation in this hospital, which is when the physician, the residents, or academy, industry, it's a meeting place. People take out the what codes and then try to ideate and to innovate within this specific place. Of course, the startup industry are coming in, hackathons, anything. This is fostering ideation and innovation, creating kind of incubator and accelerator, and of course, have some financing fund. This is another thing that we are trying to do in our hospital. We are now have a fund that is pushing ahead the industry, that are trying to introduce, of course, investors in digital health, but also companies. And now we are closing the circle. We have a hospital, we have the data, we have the technologies, we have the best physicians, we have the best smart people around, we have the hub. The ecosystem in Tel Aviv is obsessed, is looking for such opportunities, and we as a healthcare organization must provide it in order to close the ecosystem and to make it possible. So my message to any healthcare organization, you have a duty. You have duty, because we cannot go ahead and succeed in that without the pivot role of a healthcare organization to push ahead digitalization and smart AI within our healthcare system. Thank you so much.
This is from Berlin. How did you find out that this is from Berlin? So, Ronnie, again, thank you very much for hosting us. Thank you very much for working with ELNET in the GIHF-AI program as a member of the Board of Trustees. And for your next visit in Berlin, you know, over winter it's a bit chilly, not as lovely as here. So this is a sweater for our next run in Berlin. Of course, you can also do a picture with it here on Tel Aviv Beach. Toda rabba. Thank you very much.
Thank you so much, Professor Dr. Ronnie Gamzu. It's so inspirational to see a leader who is identifying challenges and running straight at them and confronting them head on. Very impressive. I would now like to invite up to the stage Dr. Yanis Tolias, the lead legal on AI and AI liability in healthcare for the European Health Data Space Team and the European Commission, speaking to us about challenges in developing and deploying AI in healthcare.
Thank you. Thanks a lot. Thanks a lot for the great event that you organized and for the invitation. And also thanks for establishing this great idea on enhancing collaboration between the European Union and Israel, especially when it comes to AI, digital, all these issues. They are so global that I think all these international and also with Israel collaboration, which is very innovative in this area, is a really superb and great initiative. And thanks for that. So as we all know, there is an abundance of health data. And in recent times, especially with the digitization of data, plus the advancements on AI, it has created a great potential to transform healthcare. However, at the same time, we see some new concerns. And I call them new concerns because we have not seen so vividly these concerns arising, for example, in the area of, let's call them conventional medical devices. We see them very much, these concerns, arising when we have AI-based medical devices. And these concerns include, for example, the collection, transfer, and use of health data. Do you have consent? Are you GDPR compliant? Can I use them for research? All these questions now that they are new. The performance of AI systems, for example, you have created an AI system in Tokyo, does it equally work well in Israel, in Tel Aviv, does it equally work well in Rome, in Paris, in Germany? These are questions, especially in the area of healthcare. The physician-AI interaction, after they are deployed in real healthcare setting, how should I be interacting with them if I'm a physician? Should I trust the AI? Should I use it as a backup system? If I have a conflict, if I do A, and AI tells me B, what would be my liability, and so on? All these questions there. Liability, which is also interlinked actually to the issues before, as I will also explain a bit later. Ethical issues, especially in healthcare and morality, and fairness. I will mainly talk about the first group, not about ethics and fairness, but this is also something we should also keep in mind. That is also especially important in the area of healthcare. Now, what are the possible root causes of these new concerns, as I call them new concerns? Here, actually, I'm injecting a bit of my own research. There is a paper published actually at the New York University Jean Monnet Working Papers 2019, so you can find a bit more of my ideas there. But I think one of the root causes of these new concerns, of these new worries and so on, is what I call the systems intelligence. In the sense that, in contrast to a conventional medical device, an AI-based machine learning system first can learn from data. And this creates a bit of a confusion. Does it learn from the right data? Does it have the right teachers? All these questions. Then they can also generalize in the sense that they can apply their knowledge on new cases that they have never seen before. And this is a bit similar to how humans and some animals think and apply their knowledge. This is what we call actually inductive reasoning in humans, and what it defines humans as being clever. As a result of that, because they have this ability now, they can now penetrate into this area which used to be reserved for humans. They can carry out tasks that have been traditionally reserved for human intelligence. In medicine, medical diagnosis, it used to be a human domain. Management of patients, human domain. Treatment, human domain. Now AI can do that thing. So how do we deal with this? I will refer mainly to 4 pieces of proposals, legislative proposals. The first one, the AI Act, which I was also involved. This one came from our unit. The other 3, I was also involved looking at the implications in healthcare. The AI Act, which was published in April 2021, the EHDS, European Health Data Space, May 2022, Product Liability Directive, May 22, AI Liability Directive, September 22. These have been proposed by the Commission. Now they are at the European Parliament, the Council, who are the co-legislators discussing, so negotiating. So what I will refer is the current proposals, but have in mind that some of the issues might change depending on the negotiations. Let's start with the AI Act. And let's focus a bit on this important question, one of the concerns we said at the beginning, the generalization ability, the performance. Does the AI system perform equally well in Israel as it performs in Germany, as it performs in Sweden, and so on? This type of question. The AI Act contains a number of requirements there. I identify 3 of them. One of them, there is a section on data and data governance. Article 10, and I will come back to it. There is another one on accuracy, robustness, and cybersecurity of AI systems. There is another one on corrective actions and withdrawal after the system is deployed. But let's focus on data, since I also saw there is also some interest in the area of data in the European data space. I pick the data and data governance, which is also one of the important areas. Article 10. If you go to Article 10, paragraph 4, it says, the training, validation, and testing data sets shall take into account the geographical, behavioral, or functional setting within which the high-risk AI system is intended to be used. So in the area of healthcare, you may be wondering, if I'm, let's say, a developer of an AI, how do I really now apply this high-level requirement? The answer to that is that, so this is the first question you may have, how do I precisely fulfill this high-level requirement? The answer to that one is that usually these high-level requirements, which are called in EU law essential requirements, which are found in the mother law, the first law which is created, they are followed usually by two techniques to make them more specific. One of them through standards, and this is something that the Commission now is contemplating. Of course, as I said, this might change, but let's say if it stays the same, the Commission now is contemplating to issue a standardization request to the standardization bodies to create a standard to provide more technical specifications as to how this would be understood and should be applied, let's say, by startup. Or, he also says in the AI Act, the Commission may proceed to adopt implementing measures in the sense of specification. So the Commission could also do it through technical committees and create more understanding as to what that is. A second question, and maybe even more important, even if I tell you, even if we say, okay, this is what it means, this is how you should do it, you might still say, okay, I want to do it. Let's say I'm a small startup. I want to do it, I want to comply with the Act, but I just don't have the data. Where can I find the data? Give me the data to be able to have diverse data to fulfill my obligations. So the second thing, where can I find the health data? Plus the GDPR. Do I have the consent of the people? Do I have the right to process them? Do I have the right to use them for research? All these questions. And here is where maybe we can come to the European health data space. The regulation which was published in 2022. And I'm referring to a part of the European data space, the second part, because there is also another part, primary use of healthcare. I'm referring to the research part, let's say, since we're talking about AI. Basically, what the European health data space, the research part, the secondary use of data will create, it will be something, this is the infrastructure. It will have at least one health data access body in each member state. And I say at least because, if, for example, in Germany, when there is more federal states with different bodies dealing with data, maybe, for example, in Germany, there could be more than one. But let's say there is one in Sweden, one in Denmark, let's say there, or one in Italy. There is the data holder. Here, for our purposes, since we're talking about healthcare, think of it the hospital. Let's get the hospital example. So the hospital, it says, the law, if it processes data for certain purposes, and it says, for example, for healthcare, it would be obliged to make them available to its health data access body. So let's say this is Italy. This is an Italian hospital. The Italian hospital would be obliged to make certain types of data. It says this type, if you are processing A, B, C, D, E, F type of data for purposes 1, 2, 3, 4, then you would be obliged to make them available to your health data access body. Now, under the GDPR, there is different legal bases of how you can process data. One of them is consent. The European health data space is not using consent. It's using another legal basis to push and create this obligation, which is not consent. However, it is GDPR compliant. It is very much based on GDPR because it says this data that you would be making available, they could be used for research, let's say startup on AI, for certain purposes. And then there is a list of certain purposes. One of them, it says training, validation, and testing of algorithms. Actually, we copy-pasted this thing from the AI Act to make a link there, to clearly make a link between using data from here to fulfill your obligations there. And also there is a prohibited list, for example, using data for insurances to affect the insurance of people prognostically, that's the prohibited list. The positive list is, for example, AI. Then you, the startup, let's say AI, you make your application to your data access body. Of course, you may also want to obtain data also from Sweden, Denmark, Norway, whatever. So you may ask your data access body to send your signal to other member states, including nodes. It could be also the European Medicine Agency, it could be CDC, and it could be also other data sharing infrastructures which could be also part of this thing. And your message could go to everywhere that you are looking for data in this area. If your application is successful, then you will get a data permit. The data would be anonymized, in certain cases pseudonymized, put in a secure processing environment. You will take your algorithm. Now I'm getting this narrative. Of course, there could be different uses. You get your algorithm, you get into the secure processing environment, you carry your research, you get out of the processing environment, and after 6 months, maximum, the data should be deleted. So that's the gist of how it will work. Now you may tell me, however, how would I know as a data researcher what data exists if there is thousands and millions of data floating around? The answer is here that if you're the hospital there, the data holder under Article 41 of the EHDS, you are obliged under 41 to give a general description of the data sets that you are holding. So the hospital says, let's say the Belgian health data access body, I am holding data, for example, so many MRI images, so this, so that, so that. So you create a general description. Then you create under Article 55 a metadata catalog. And then the researcher would be able to read the metadata catalog to see what data you hold. This is, let's say, Italy. This is now Sweden. Sweden and Italy will send this to the European Commission, who is obliged under Article 57 to create a data set catalog, a European data catalog, so the researcher would be able now to see in the whole of the EU what it exists. Now, let's go back to AI Act, and let's look at another part of the data and data governance obligation. Article 10, paragraph 2, it says also another obligation. Training, validation, and data sets shall be subject to appropriate data governance, including annotation, labeling, cleaning, enrichment, assumptions, biases, data gaps, and so on. So as you can see, it also creates a lot of other, let's call them data quality obligations. And now, another interesting question would be, okay, what is now the connection between my obligations there and the European Health Data Space, especially if I'm using data from the European Health Data Space to fulfill my obligations there? The answer is there, which might help you. This is the hospital giving data to the data access body. If you're giving data to the data access body, your data may, it says, have a data quality utility label. And I will come back to the data quality utility label. However, if you are a holder of data which you have been funded by member state funds or EU funds to collect and process your data, you shall have a data quality utility label. What is now data quality utility label? A data quality utility label, it says, it's a label which should contain information on biases, accuracy, uniqueness, enrichment, So you can see there is the word also biases there and biases in the AI Act. Of course, still you may wonder, what is the standards? Would it require third-party assessment? Who should deal with this thing? Paragraph 5 of Article 56 says that the Commission will adopt implementing measures to specify this and should also take into account Article 10 of the AI Act. So as you can see, ideally what it should happen is that the AI Act provides some information on, let's say, data. This would be done through standards and common specifications as to what the meaning is. The European Health Data Space has some data quality requirements. These would be also done in specifications, and at some point, ideally, these two should be talking to each other. There should be correlation there. Of course, let's not forget that the AI Act is not only about AI in healthcare. The AI Act is also applicable to all high-risk domains, not only healthcare, so it wouldn't be specifically for healthcare. And the same thing with the European Health Data Space is not only for AI. It's a data space which you could use data for many other purposes. Now, I think at this point, maybe let's inject a bit liability, because I think that's also where it suits a bit to also talk a bit about this proposal, which was published in September 22. I will start with the products liability, which is, there is a products liability directive in the EU, 1985, and now it's being amended. This is an amendment of this is a proposal for amending the existing product liability directive. These are the players in a product liability directive. You have a manufacturer which is creating, let's say, an AI system, or even pharmaceuticals, because it's a horizontal piece of legislation. It's not only for AI. And then you have this product causing damage. The important thing, the most important thing actually for the product liability directive is that you should have a defective product. If a non-defective product causes damage, there is no liability. A defective product which causes damage, there is liability. So one of the issues that the Product Liability Directive intended to answer was what type of damage should be compensable. And it came to, in addition to the standard ones, death, personal injury, it came, for example, to also psychological health, especially in AI, if it creates psychological health, now it is a compensable damage, but also to loss and corruption of data and so on. So it came a bit into a bit more, let's say, new type of damages that you could ask for compensation. However, especially for us in the area of healthcare, one of the important discussions a bit in the 2018, somewhere there, when we started vividly discussing about this thing, was about the effectiveness of the AI system. How do I determine when an AI system is defective? That was one of the big questions. How do I determine when an AI system is defective? And there were different discussions academically, you should do this, you should do that, you should do the other, and so on. The Product Liability Directive adopts this following, and also in the case of pharmaceuticals, maybe not so much for AI, there was also a question on causation. How did the vaccine cause that damage? These type of questions. So there was causation issues, especially in AI, I would say defectiveness. What is defectiveness? The technique that the Product Liability Directive, if I can call it technique, adopts to resolve this issue is through presumptions. So it creates presumptions on defectiveness, presumptions on causation. And let me explain in 1 minute what we mean by presumptions. First, it says, if your product, let's say for us, because it's a horizontal piece of legislation, AI-based system, let's say, fail to fulfill certain mandatory safety requirements, it will be presumed to be defective. So if you think of it now, what it could mean for an AI-based medical device, which will be subject to the AI Act, which will be subject to Article 10 on the data quality, it means that if you have failed your data quality, let's say, obligations, you could argue that it's a safety requirement that you failed, so it renders the AI system presumably defective. Now, of course, you may say, but how do I find this information? Now, poor me, the claimant, how can I really find out if they have taken into account their obligations, There is Article 8 now of the Product Liability Directive, which says that the national courts are empowered to order the disclosure of relevant evidences. So you could ask now the court, you know, I want to find out if they have really taken into account biases and If now they don't disclose this information, then it could be creating a presumption again that the product is defective. So you're playing a balance there between helping a bit the one who is bringing the action and also at the same time, I would say, giving some protection to the manufacturer of the AI in the sense that if you have complied with your obligations, you will be, I wouldn't say prevented from having an illegal action. It doesn't create a safe harbor in that sense, but it shows some balances there, I would say. And also it says if there is an obvious malfunctioning of the AI system, of course this might be an interesting concept, I wouldn't get into it, when would we consider the AI to malfunction? This is an interesting thing. Actually, I will give a talk on Thursday on this thing at the university in Santana, so you may join and listen about more liability issues and this type of issues. So this is a bit what happens. Now let's jump another couple of minutes and I'm finishing. I think my time maybe is going. It's almost there. On the AI liability directive, which this is the other proposal I indicated at the beginning. The other, this is the directive, this is a proposal which is applicable specifically to AI. The players now here is a faulty defendant. Of course, here doesn't mean it's only the manufacturer, it could be also the user. So the user in the area of healthcare, if you think of it, might be also the physician in that sense. So here, it also encapsulates beyond the manufacturer, also the user, which, as I said, might be also in principle, at least in principle, the physician. I say in principle, I use the principle because it requires this directive that the system causes a damage. So in theory, if you have, okay, that's good actually, I see there is a very nice system there showing my time. So if you have a standalone, let's say, medical device, which provides information to you, as a physician, and then you apply that information, this would not be applicable. So here we're talking about something, especially in the area of healthcare, which might be not in existence now, an autonomous AI, let's say, robotic surgery, which is completely autonomous, and it creates the damage, and somehow the physician is controlling the environment rather than. So it's a bit, at least in the area of healthcare, not immediately applicable, because it wouldn't be applicable to standalone software which provides information to the physician who then acts on that information. But this is the idea. What it does there is that if you find someone who is negligent there, the question would be, or the question that this directive aimed to answer was, would it be, if you find that someone did something wrong there, would it be what is their connection to the output? What is their relationship between that one and that one? And what it does, so the focus is there, it creates also a presumption of a causal link between your fault and what that guy there decided. So that's what it does. So, as I said, we talked a bit about this issue. This is a very important part too. Let's not forget about it. And I'm not going to get into the details of this thing, but just to give you a couple of examples. We also see that the AI in healthcare sometimes performs really well in, let's call them in the lab. However, when it's deployed in the real environment, in different hospitals, it doesn't perform so well. For example, we have seen, actually, I was in another conference, and they were presenting an AI system which was performing 98% in the lab. When it was deployed in the real healthcare setting, 30%. It dropped so badly, 30% performance in the real healthcare setting. Or there was another research in the US. The same type of system was deployed in two hospitals, teaching hospital, non-teaching hospital. Teaching hospital, the rates of death have dropped. Non-teaching hospital have gone up. And my last slide, concluding. In 2017-18, we were talking about these issues in a very theoretical manner. Actually, I was also in New York doing my research fellowship there, and it was very theoretical, these discussions. It was interesting, but theoretical. We have now reached the point, at least in the EU level, where we came quite fast, I would say, in 4 years' time, with an AI Act, an EHDS proposal, a liability, the MDR, which was adopted in medical devices regulations 2017, entered into application last year, and possibly court jurisprudence, which will be developed. So we reached a point that at least we have a framework now to understand this technology, so hopefully, of course, now the challenge is to see how we should connect all these initiatives to create like a boost, uptake, and upscale of these technologies. Thank you.
Thank you. Thank you very much. Thank you very much, Dr. Telias, for this inspiring keynote, and it's impressive to see what the European Commission is actually doing. we are a bit behind schedule. Nonetheless, I'd like, if there are any questions now here on the stage for Dr. Tolias, we have the opportunity now. Otherwise, you have the coffee break, the lunch break, the workshops. There is a question.
Thank you very much for your talk. Just wondering if there's any thought about the commercial aspects of data holders in two aspects. One is the hospitals in Europe it will cost them a lot of money to transfer the data to an access body, and how is this going to work? And startups asking for grant for research, will they need to pay? Who will they pay?
Yes, indeed. Actually, there is some provisions in the European health data space that provide for fees. They are not determined yet, but indeed there will be some fees involved of the one who is processing data, especially if they have enriched the data, have they spent money in doing something, and how much you should pay. This is something that it would be determined at the later stage, but indeed this would be taken into account, so the data user would need to be paying some money, especially if you're getting enriched data or for the cost that they incur to create this data. Yeah.
Okay, ta-da. All right, I see no more questions for now. So again, thank you very much.
We have one more question.
Oh, one more, okay.
Okay, one more little question.
Yes.
You just mentioned the European health data space, and you had a slide about the health data access bodies, and in the core, in the middle of your slide, there were core services delivered by the European Commission.
Yes.
And I was wondering, what are these core services? It could be as well a health data access body on the European level, which would be perhaps quite useful for the member states.
Yes, actually, in our team, we have different kind of groups, and there is a technical group dealing with these core services, you say. These ones could be, yeah, I don't know to what extent there will be a European data access body, but it could be, for example, core services on, now I'm just saying some potential on the secure processing environments, for example, whether you need one secure processing environment in each member state, or whether you also would be recommended to have one central one. So if you are especially using data from all over Europe, then if you ask everyone to throw the data in that secure processing environment, so you go in one processing environment, for example, you do your research rather than having to jump from one member state to the other. But also coordinating, yes, I can give you more information on what at least we have in mind. You can send me an email, and I could also ask a bit our technical colleagues what is there. But indeed, it will be something at EU level, Commission level, which will be having these services at that level. Yeah.
Okay, very well. Again, thank you very much, Dr. Tolias, for joining us here today from Brussels. Well, next we do another jump. We stick with the authorities, but now we will focus on the ministries from Israel and from Germany. We will hear more about digital health and AI, 2 countries, 2 perspectives, 1 goal. And let me take the opportunity, I already mentioned it last night as we had our reception dinner, how delighted and how grateful we are to work so closely with the 2 ministries. First of all, of course, with the team of Dr. Susanna Otzegowski from the German Federal Ministry of Health, who is funding the GIHF-AI program for the length of 3 years, but also together with Esti Shelley from the Israeli Ministry of Health. Her ministry is actually supporting this conference. So thank you very much to both of you and your teams. We already had Yoel Ben-Or, who is working very closely here from the Israeli ministry with a question. So thank you very much for all the support for the program and the great collaboration to you and your teams. I think this deserves also applause for the ministries. So, and without further ado, I'd like to ask Esti Shelley on stage, the Director Digital Health at the Israeli Ministry of Health, for her remarks. At the podium. Okay. So, Esti, welcome. Thank you very much.
Thank you very much. I will try to meet the delay in our schedule and try to fit it shorter than 15 minutes. So let's try this challenge as well. Thank you very much, Karsten, and everyone for being here today. I will try to focus on actually a question that I have been asked at the ministry several times during the last year, is why digital health is such a global challenge, why we are working so hard on collaborating, for example, with the German Ministry of Health, and why it is an issue that we need to put our resources on. And I try to, of course, to link it to digital health in general and AI, which is the focus here. So healthcare is very local. Think about it that maybe medicine might be a very global issue, but healthcare services are very local. It's not very easy to transform or to deliver healthcare services cross borders in other countries, and especially Israel, which is not a member of the European Union, and we are kind of an island in this area. So why it is so important? I would like to give two examples. One is to talk about data portability, and thank you, Jonas, for the presentation. I think a lot of it is going to build up on this issue. And the second one is the AI and software as medical device, which is another challenge that we are all facing recently. So when we are talking about data portability, and again, the last presentation described the concept of health data holders that should be enable data transfer to a third party, and this is something that we are also working here in the ministry, putting a draft legislation that is going to be submitted to the new parliament here in Israel. And we are seeing the process of the democratizations of tools that are being used for patients, but also for the practitioners in the healthcare system. And there is a huge challenge that we are trying to look at, which is to balance between the patient right to have access to his or her own data, but also the issue of privacy and data security. So how we can make sure that on one hand we are able to give the patients and the public and the physician the maximum tools that are available to use the data, on the other hand not to be too paternalist of how he or she should access the data and what kind of privacy and the data security tools to be in place. So we can choose two approaches. I mean, this is the debate that we are actually having here also in Israel. We can be very liberal, and we can decide on a policy regarding data portability, for example, that will be very liberal, even more liberal than most other countries. And you know that we have the US and the European approach and the UK. And that might bring a lot of innovation into Israel, and maybe will make Israel like the most innovative place to work in. But that we are risking, I mean, as looking from government point of view, we're risking the public trust. Because when we are very liberal, sometimes there are faults, sometimes there are problems, sometimes you take more risks than you're usually taking. And when we are talking about healthcare, we are talking about public trust. And yesterday we were just talking with Sylvie and Ran about how the public sentiment is regarding privacy and trust in the healthcare system. Not talking about trust in government, this is another issue, but we are talking about the trust in the healthcare system. We don't want any patient to really reconsider and think again whether he would like to get care in this clinic or in this hospital in terms of trust and security. And we can take the conservative approach and say, okay, maybe we should, check gazillion of things before we are letting anyone access the data that we are holding. But then innovation will go first to other countries. And Israel is a small country. It might not come here later on. That's an issue that we are that we are facing. And when we are thinking about fostering innovation and also implementing the issue of data portability, that we really believe it's a patient right to have access to his or her data, We need to be aligned and to think deeply about all those aspects, not only from our Israeli perspective, but also thinking of with other players like our German colleagues and the European Commission as well, to understand what are the policy decisions and what are the right balances that we are able to take. Another issue is the AI regulation. One of the questions that we are asking here in Israel, and we are debating on some aspect, whether Israel can be a better site for AI. And we are doing a lot of work. I'm looking at Anat and Ran here that are working in this field, but we're doing a lot of work trying to bring more AI companies here to Israel and make Israeli healthcare organizations like a very good, better site to explore. But I mean, on one hand, we would like to see wide adoption, and we as the regulators are really willing to take new risks in this field, and we are working a lot of thinking of what is the right mitigations that we need to take, etc. But on the other hand, when we are talking about real-world evidence and AI and software as medical device, we know it's very, very local. In the end of the day, as happening in Germany with DIGA, but also in other aspects, we would like to see that the validation will be done on our data set, on our population. And I'm guessing that as Israel would like to see it, as many other countries would like to see the same. Because in the end of the day, we don't want to see a technology or algorithm that was tested on, I don't know, on Japanese population, which is very different from Israeli or German, that might be very different, and how we can implement it securely here in Israel without understanding the limitations of working with the different data sets. So in order to understand what is the process of validation that we need to do, and not just saying, okay, that comes from Japan, or that comes from the US, or comes from Germany, and that means that you need to start over because you're coming to a new market, and we would like to see out on the Israeli population. We need to understand better and to work and to be aligned between different countries. The policy needs to be really aligned. So we will understand what is the gap, what is the difference that we will need to adjust here in Israel before we are able to use those technologies, and vice versa. If we will know what is the difference and how we can be aligned in different policy aspects towards the approval, we will be able to minimize the cost for those AI companies or other medical technologies in their implementation process into Israel. So I think just to give a sense of two aspects of data portability of AI, which are two topics that we are currently working a lot on, to give a sense of why and how we are looking on international collaborations and why we are really deeply invested and happily invested in the collaboration here with the German Minister of Health with the support of ELNET, which provide a very good platform for collaboration. What we are really looking forward is to see what is going to happen in the working groups that we are having later on today, which will bring everyone to sit together and to exchange ideas and views to see how we can move forward on those topics. And without further ado, I think I shortened our gap. Yeah, great. So thank you very much.
Thank you so much, Esti Shelley. And thank you to Yoel's counterpart as well, Eileen Lersmacher. I am about to introduce our last speaker before your coffee break, so perk up. Dr. Suzanne Otzakowski, to give us the German perspective.
Thank you. So actually, this is real justice. Yesterday, Esti was the last one to talk before you had dinner. So today, I'm the last one to talk before you get your coffee. So I think we're even now. So I will also take up the challenge of shortening our delay, but I would like to give you...
I'm sorry.
Okay. Then I'm stuck here. All right. So I would like to give you a short glimpse into what we're dealing with in Germany at the time, and I hope you will be able to pick up a lot of these issues in more depth later on in the different roundtables. So let me skip this first slide and jump onto this one, because what we're basically in the middle of doing at the moment is that we're putting together our digital health strategy. And when looking at what we've been doing in terms of digital health over the past years, and actually I might say decades, in Germany, is that we've been talking a lot about the different puzzle pieces. We've been talking about how do we get an electronic health record? How do we make e-prescription a reality? How do we make sure that research has health data? How do we make sure that doctors can interact with each other and exchange information? How do we get prescription apps going? And so on and so on. So lots of different puzzle pieces. And what we're trying to do at the moment is to answer the question, how do we bring all these different puzzle pieces together so that they make a full product and, which I think is even more important, what's actually the place where we want to go? So what's actually the vision of what do we really want to achieve? How does that, what we are talking about each day, how does that make healthcare better? How do patients get treated better? Or how are our physicians, how do they have a better working place because they get rid of a lot of the bureaucratic things that they have to do? How do nurses have an easier working place? So what's the place where we want to go? And how do we get there? So what's our roadmap? How do we have to set our priorities? What are the things maybe that we've been doing in the past that we should put aside a little and focus on the things that have the major impact? So that's our big challenge basically at the moment, and we've been debating a lot over the past months with more than 100 people in our healthcare system coming from all the different stakeholder groups to put together the strategy. And if you want to know a little more, actually one of our colleagues, Lars Hunze, who's also here today, he is right in the middle of doing all of this, and I'm sure he'll be happy to answer all of your questions on that. So at the moment, actually, like after having the, I would say, the fun part of this strategy process, which basically was collecting all of the input, talking to experts, doing workshops together, we are now at the point where it's really heavy work because we have to bring all of this input together and try to make a strategy from that which really makes sense. And so the next step will be that we will collect feedback on a preliminary version of this strategy in order to then, at the beginning of next year, be able to present the strategy. And of course, we are all very well aware of the fact that whatever we are presenting there, especially when it comes to the long-term vision, we will never have a situation where we say today, this is how 2030 will look like. 2030 will actually look like what we are saying, how it should look like looking from today, because of course things will change. But nonetheless, we believe that it's very important to have a benchmark against which we are able to set priorities and against which we are able to say today what are the things that we really want to invest in. And one thing that we can already say today, what will be a major component of the strategy is the electronic health record. And that is because we need one place, or we need one instrument which allows us to collect the data that is generated each and every day in healthcare. Today we have, like, all of our hospitals have the clinical data, the ambulatory care physicians have a lot of the data. each patient, of course, has data which he generates, for instance, by different digital health apps. We have data that is collected within our sickness funds, and so there has to be a place where all of this comes together, and this is why the electronic health record plays such an important role for us. One aspect, of course, in that field is also that we don't want to have any kind of data in there, but of course we are talking about structured data, and I'm sure Sylvia Thun, who is our basically each day reminding us that this is something that we should really focus on, and she's right on that. So this is actually tough work also in Germany, as we are in a situation where we have more than 100 different IT providers just for ambulatory care physicians. We have many more IT providers for hospitals, for dental care, for mental care, and so on and so forth. So that's why interoperability is really a focus topic for us, because otherwise we will never be able to get data in the system which also makes sense and which is really usable in that aspect. One thing that will also be an important part of the strategy, and I said before that prioritizing is really an important aspect, and this is also important when it comes to interoperability, because one thing we have learned over the past years was that it really takes a lot of time, especially because the industry plays such a big role, and at the Ministry of Health we can write a lot of things in our laws, but this doesn't mean immediately that all of this is implemented in practice. So that's why it's really important that we set the priorities right. So what we're doing at the moment is that we're reprioritizing what are really the most important data types that we need to be interoperable, and what are the things that we can maybe put a little aside and say, okay, let's save this for later. And to give you a very concrete example, we've had as one of the priority topics in the past having maternity records interoperable, and of course maternity records are important, but I mean, let's be honest, this is probably not the key thing and the key data type that we need in order to make healthcare better. But we're rather talking about medication data, lab tests. I think that's the kind of information that has to be the #1 priority, that has to be interoperable in order to really make healthcare better. One aspect, of course, in order to make the electronic health record is that it has to be not on paper, but it has to be live and in practice. And today we're at this point, we're at less than 1% in our population who have an electronic health record. And so where we have to get is to at least 80%, because otherwise each doctor, has to search a long time until he finds a patient who actually has an electronic health record. So one instrument which will be very important for that is to change from an opt-in system to an opt-out system. And this is something that we're looking at for the year 2024 to be live and in practice, in reality. And what is very important also in this setting here is that we don't want to have opt-out just, I would say, for primary use of data, but also for secondary use of data in terms of research data. So that means that our vision and our goal is that all of the data that goes into the electronic health record will immediately, unless the specific patient opts out, that this data will automatically also go to our health data lab where this data is accessible for research purposes. And if this becomes reality, it actually means that in a long-term vision, this will enable us to have like almost real-time data available for research purposes. And so this is something that I think will be of really big importance in order to finally have also the data infrastructure in place in Germany to make us able also to use all of the goals and the things that we connect with topics like AI, as we've been discussing this morning. Of course, one other big aspect, and I elaborated a little on that last night, therefore I will skip it for now, is usability. The EHR will only become reality when people use it and are able to use it, and in order for that to be reality, I think there has to be a fully digital way in order to access your electronic health record. We at the ministry do not believe in a way where people have to handle different ID cards, stuff like that, in order to access their electronic health record. And another aspect is that we have to move this electronic health record away from this thinking of this is a health record in terms of an electrified paper record, but it has to be a tool which you can use and where you can actually get an immediate benefit both as a patient but also for doctors. And of course connected to that to create like a real health data ecosystem in the sense that I mentioned before, that it's not just clinical data from your different providers, but that you're also able to integrate the data from your other health apps, for instance, to integrate the data that the sickness funds collect, and to integrate the data that we collect with DIGAS. And this will be is another important topic for us, of course. Over the last legislation, DIGAS have been introduced, which actually I think has been a great step, and I'm so happy and always so proud to have something like this, especially when I'm in an international setting, because for once at least I do not have to be ashamed and embarrassed when talking about digital health in Germany, because this is really something where we are front runners. But also there's still a long way to go until we really make the most use out of this. It started very small, and I think it was right to start on a small scale, because otherwise we would still be debating about it. But of course we are very well aware that in order to make really the most use out of data, out of DIGAS, they really have to be integrated into the care process, and they should not just generate data for for other purposes, research purposes and so on, but of course it should also be possible to use your data from your electronic health record, for instance, to make them usable for the DIGAS, and to make them better and personalized, and for instance also on an AI basis. Yeah, actually I've been talking quite a bit about this already. Of course, better healthcare will only be possible if we use the data that is available already today. I think the COVID pandemic has been one of the best reminders of that, and it's been quite embarrassing for Germany actually that we've always been looking at Israel in order to decide what our vaccination scheme should be. And I think it should be our aspiration to also in Germany be able to generate studies. And just like Esty just said, of course, you can use data from other countries. And actually, this is practice in Germany each and every day. But we, of course, we want to make use of the data that there is in Germany, because, of course, there are differences between countries in terms of population, behavior, and so on and so forth. So this is what we're aiming at, and for that, our health data lab will be a very important project in order to realize that. This is something that we want to realize next year, starting with the Health Data Lab. So a place where we really can where researchers can tap into all of the different data pools that there are in Germany. One other thing we're doing at the ministry is that we're also trying to get AI-based use of, or AI use in healthcare going through different projects. Actually, GIHF-AI is one of those projects, but there are also quite a few projects which are where we're funding a very direct use of AI in healthcare. things like, for instance, real-time translation in a hospital setting, different applications when it comes to, for instance, merging cancer registries or the use of AI in crisis management. The EU health data space and our law on health data use, these are two aspects I've already mentioned last night, so I will skip on that, but these are very important things that we're working on at the moment in order to bring all of these things which I just pronounced as ideas, to also bring them in a legislative format and bring them onto the floor. And so I think, actually, I just noticed maybe this picture is not really tailored right here to an Israeli setting, but nonetheless, I hope you can still relate to it. So the place where we're at the moment is that we're trying to make out where do we actually want to go and what's really the goal that we're trying to attempt. And we also know that we're definitely not at the top of the summit, and we're also not this group which is almost at the peak of the mountain, but we're lagging a little behind, but still we're confident we will also at some point reach the peak. And well, actually, if you've ever walked through really freshly fallen and really deep snow, then you will know that actually sometimes it can be helpful if you're not the first one, because this is where you have the real hard work. So actually it helps to have a track that you can actually follow. It's a little easier to go, and in that sense, I think this conference also helps us a lot because we can benefit from the experience that you have already collected here in Israel. And so we have a little of a track that we can follow, but I'm sure that here and there we might also find a different path and a different track and basically create that on our own. And hopefully you can also benefit a little from that, from our experiences. So I'm very much looking forward to our workshops this afternoon, and now I guess it's time for coffee. Thank you.
We would like to begin the second portion of the event. So if everyone could again, yeah, sure. Here. So if everyone again could silence their phones, that would be wonderful. I'm going to take a moment to introduce Professor Dr. Ran Balitzer, who is the Chief Innovation Officer at Clalit Health Services and our resident national expert in all things COVID, to speak to us. Again, we're going to have two perspectives on the same issue. So before we looked at digital health and AI, and now we're going to look at transforming care. Thank you so much.
Thank you, guys. Good afternoon. We're after lunch, which means you're all dozy right now and you kind of feel very comfortable. So enjoy and relax. And we'll, in the next 15 minutes, what I'll try to do is to a little bit of walking the talk, in the sense of everybody talks AI, everybody aims to do AI, but the amount of AI that actually reaches the trenches is not that great. And I'm saying this in the most euphemistic way possible. The promise that lies in digitization, in the use of data, in advanced analytics, in AI is tremendous to transform healthcare for the better, and that's something that everybody agrees upon. And then there's this, okay? Great hopes, very few achievements. And this is not just true for a single healthcare system that feels it's lagging behind. This is a general sentiment that feels that we've been overhyped and under-delivered in the field of using some of these things in practice. And I don't think there was a place or a time this was more clear than during COVID. I don't know what your expectations were, but it was my expectation that within 2 months after this new event comes in, we will be swamped with AI based on imaging studies that will be able to instantly detect unknown COVID, and we will not need any clinical signs and symptoms, that apps will come out of the blue that allow us to manage this better, that when we do a test, we will be able, at home, we will be able to easily share and create records very easily. All these expectations were completely not supported by what actually transpired. I will take 1 minute to tell you what we did for a second during COVID-19 in terms of taking things to practice. As early as March 2020, we have already been able, using our data in ways that you will later understand how that came to be, we were able to create our first predictive model on the risk of patients to deteriorate to severe COVID-19. Based on previous work we'd done with flu and data, general data that came in from China and Italy, and we were able, in a pretty advanced approach that actually is able to do post-processing of existing models and turn them and align them with existing data, we were able to predict very accurately which ones of our patients are going, when they get COVID, they will deteriorate. And we've identified within our 5 million population 200,000 people that were the highest risk. And when we identified these 200,000 people that will be at the highest risk, our physicians have called each and every one of them during March of 2020. If there are any Clalit members here, they would vouch that that is true, that their parents and that people that they know have received calls from their GPs and from their clinics saying, there's a new disease out there, it's called Corona, you've never heard of it, but it's going places. And maybe, just maybe, when you are feeling ill, you should not come to the clinic. Maybe instead, you should call us, and we will either come to your house or we'll give you online care. This is not a theoretical construct. This is what happened in March 2020. And so taking this thing from theory to practice, from bench to bedside, to implementation, to mass implementation, to nationwide implementation, and seeing reaping the benefits of it did not come out of the blue. It came from a lot of prior art that I'll discuss briefly today. So the reason that so little is actually being delivered, it's not privacy. It's not interoperability. It's not standards. It's not money. It's this, basically. We work in the gut of a dinosaur, and our systems are exceedingly conservative and proud of it. Some of it is absolutely just. It was already said that we should not look lightheadedly at innovation in healthcare, because the implication of a mistake could be devastating, and I accept that. But still, while this is the case, I think that we are definitely not moving at the speed we should, and that's due to really state-of-the-art conservatism. And the reason we have to move forward is known to all of you. I will not spend time today explaining this. You know this. You know the patient is becoming older and more multimorbid, the population. You know that the technology cost is skyrocketing. A few days ago, there was a new technology that was approved by the FDA for treating hemophilia. You know how much a single dose costs? $3.5 million, yes. Single dose. So this is not going good to sustainable places, okay? Patient expectations are rising, and justly so. We do not accept the fact that we'll go and stay now and wait for 2 hours in the line because nobody bothered to adjust the timing accordingly. And that the amount of health staff is continuously decreasing vis-a-vis the needs. So this doesn't, something's got to give, okay? This is a down-going spiral, and it's going the wrong way. We cannot continue this. We have to change. And you know, our patients are suffering because of this, and our physicians are suffering because of this. And they're equally miserable. And so, if we want to change, we can't do small small changes, adaptations. We really need to profoundly transform the way we provide care. And the whole issue of innovation and the whole issue of data use is not about research, it's truly about changing how care is being provided, and this is what we're trying to basically do. And the first thing that we've been looking at for the last decade and a half is the issue of looking at someone and knowing, imagine that you had a gift, okay, each one of you personally. You had the gift, you can look at someone and know that something bad is going to happen to them, but not only that, that there was something you could do that would take them out of harm's way. Now, if you had that gift, would be great, right? If you were a mechanic, you'd completely transform the way you care for cars, right? It's obvious. And if you were a physician, maybe instead of the patient coming in with their ailments, she would call you one morning and say, "Good morning." "Good morning," you reply. "How can I help you?" "Yeah, you know, how are you doing?" "I'm doing fine." "Why are you calling me?" "Well, you know, our data suggests you'll have a heart attack in the coming week, so if you wouldn't mind coming to the clinic sometime later this afternoon and we'll fix that." Yeah, but it's insane, right? It's exceedingly futuristic and improbable and will never happen, only that it does. It's happening at Clalit in many instances for the last 14 years. We created our first predictive model in 2009, not 19. And in that program, we have predicted who will have end-stage renal disease 5 years from now, and that was before he had any signs and symptoms, and we intervened. In 2010, we sent emails to the physicians begging them to care for specific patients because our data suggested they will deteriorate. We moved along from the emails, as you'll see in a second, but the concept was there. And what we could do is we could look at data, if the data spans more than 5 years, and you can say, "Oh, look what happened, there's a subgroup here. When we follow them up for 5 years, we know who will deteriorate and who will not." And this ability to do that is the gift that I've talked to you before, and I've asked you to think, what would happen if you had that gift? So we are fortunate to have 25 years of data on over half of the Israeli population, cradle to grave, primary care, specialty care, hospital care, pharmacy, data, imaging, structured and unstructured data, and nowadays also infused with omics and any other type of data. So that is helpful. But it's only helpful if you know what to do. And hoarding lots amounts of data is not always helpful if you don't have a specific aim in mind. And our aim is to transform care to predictive, proactive, and preventive care from the current state of affairs. And for instance, since 2015, whenever our nurses in our clinics want to call their patients in the winter and tell, "Why don't you come in for annual flu shots?" they never have enough time to call everyone. They only can call a fraction. So who would they call? In the past, it was, you know, those who had their alphabetical order. You know, if you're fortunate enough to start with an A, then you're in good shape. If you start with an O, well, you have a different likelihood of being called. Okay, that's not ideal. So what we did is sort those lists according to the predicted risk of the patient having winter morbidity based on influenza that coming next winter, based on all the data we've accumulated for years before. So suddenly you approach the patients in a much smarter order, and that is impactful. So this is not a small change. This is truly a paradigm shift from patient-level reactive therapeutics to population health, predictive, proactive, and preventive care. And this is very hard work. Nowadays, we infuse these models with new types of data because everything could serve to, as an input there. Anything from whatever comes out of your smartphones to the wearables, to the extendables, to anything else that you can think, and of course, omics comes to play. So as early as, when was it? I can't see, oh, published in 2020. But as early as 2018, we've been able to show that using unstructured data can allow you predictive power on who will and who will not break their bones, just based on the CT assessments with some smart AI in the background. And when COVID came in, we have utilized our ability to match people according to a lot of different aspects of their characteristics, phenomic and others, in order to create the ability algorithmically to assess, for instance, the impact of the COVID vaccine. In the same way we could identify for the first time some of the adverse events of the COVID vaccines, or we could, there's a lot of things that you can do. And basically, we were able to do a near real-time assessment of whether the vaccine works or not and to whom, and that was critical in making decisions in this country about things like, do you open the lockdown or not? And if, and which is the true case, in the middle of January 2021, we were 1 month into vaccinating our elderly population, but the numbers of severe cases kept increasing. And the decision makers had a very hard and problematic dilemma. They were almost at capacity within the hospitals, and if you open the lockdown and you're mistaken the vaccines don't work, you're going to reach Lombardia, New York, Hong Kong. Deceased people lying in the ICUs with not enough time to take them out. And if you make the other mistake, you say, okay, I'm leaving everything in a lockdown, the population at some point, well, you can see the pictures now in China, how that looks like. So neither of these are happy pictures for politicians. But you need to make a decision. And the ability to create real-time assessment and a substantiated, epidemiologically sound causal inference model was critical in real time. I would also tell you this is not only effective, this is also cost effective, and this is another one of the interventions in the older multimorbid patients, one of the largest ongoing trials in the world to this population that is highest cost. And I can tell you that we've been able to show that by focusing on the highest risk patients based on predictive models, we could reduce their costs and reduce their admissions by 43%. The right intervention, nurse and physician-led intervention to the highest risk subgroups has been able to reduce morbidity and actually reduce cost per patient. So, it's all about implementation at the end of the day, that physicians are sick and tired. And in order to allow them to be confronting this, we created a new platform that coalesces all of our predictive powers into one screen, basically, and allows us to provide the busy physician with immediate, edible decision support in real time that identifies just the right patients to care for this week. And for each one of these patients, just the right predictive models and interventions that are most needed for that patient. And at this point, what these interventions are, he can mark them and then press a button, it goes into the electronic medical record. And that's truly a transformation in the way they work. This is not a theoretical construct of a research process. This is on the screens of 750 physicians at Clalit, and by next year, everybody will use the system. And we allocate time for predictive proactive work in their schedules. So, this is the difference between the construct of AI somehow miraculously transforming practice and looking at this from the lens of the individual provider and allowing them to make the best use of this data. I'll finalize by a paper we wrote quite a few years ago. We said, what's the secret recipe? I mean, how does that work? Why is Israel going to be the digital health nation? And it all boils down to these 5 things. To the integration we have, functional integration, not data integration. The integration by design. Clalit is primary care, specialty care, hospital care under one roof, and it's the payer and the provider, and it cares for the patient for the entire lifespan. So we not just want to keep him healthy because of the Hippocratical oath, we want to keep him healthy because that makes sense financially. And that's not true for many healthcare organizations worldwide, but it's true for us. So that's helpful. The investment in primary care is key. The incentives are well aligned. IT infrastructure is important, but it's not the entirety of things. We put too much effort there, we need to bear in mind everything else. And of course, the innovative spirit. But at the end of the day, with all of the importance of the advanced technology and the mechanisms and the AI going into practice, at the end of the day, what the AI will do is augment the work of the physicians in ways that give him time to go back to the basis of a profession, which is caring for his patients without all the clerical work, without all the routine work, without all the repetitive work, and bring back into medicine the basic aspects of human touch. Thank you.
Thank you. Oh, it's loud. Thank you so much, Ran. An inspiring presentation and also quite humorous. So I think the right mix after the break and after an intense day. But I see that everyone is still very much awake. So thank you for informing and also entertaining the crowd. We have a next distinguished speaker. Actually, to start with the most important things in her CV, she's a member of the Board of Trustees of GIHF-AI. Among other things, earlier this year, she received the Federal Cross of Merit from the German President for her efforts in standardization of medical data. She's a professor at the Charité in Berlin and also a learned an engineer by education. So please join me in welcoming Miss Professor Thun on stage. And she will introduce the upcoming GIHF-AI study.
Yeah, thanks a lot, and I'd like to give you a short introduction to the upcoming GIHF-AI study. First of all, I work at BIH, at Charité. BIH is not the NIH, so it's not the National Institute of Health, but the Berlin Institute of Health. And our mission is translation from bed to bench side, as Ran already said. So we were just hosting the World Health Summit, and hopefully some of you joined us here. So the Charité is quite big. We have more than like 18,000 employees from 119 countries, and right now we have a new collaboration with the Sheba Medical Center, which will focus on strategic scientific and academic cooperation, whatever that means. Hopefully it means to share knowledge as well. And we have now in Berlin one platform where we can share data with more than I think 15 different hospitals, and we have access to the reports and access to data based on the so-called FHIR and IHE standards. So, and we are quite proud of this because it was a lot of work beside the work within the National Network of University Medicines against the pandemic. So, the new study is we work together with the eHealth Analytics company, and you see here Alexander. He is right now in Cambridge and couldn't join us, and he says hello to all of you. And he does this work since 12 years, and we have each year this survey with more than 5,000 participants, and so that we know how eHealth is implemented in Germany, and it could be like an advice to decision makers if we know what's going on in Germany and how people feel about eHealth applications. So the content is about everything in eHealth: telemedicine, apps, diggers, insurance affiliations, and so on. So the key message of this survey is to have more knowledge of the eHealth and DiGA market in Germany, and we want to measure the eHealth reality. So, and one result, or I think the most important result, is that it shows already that German population seems to be more open to digital health or vital data sharing than policymakers and EHR infrastructure allows. And I think all of you know that we don't have an EHR infrastructure right now, just a small one with only data that is from the reimbursement sector, and with data which is more or less free text. So no really working EHR infrastructure in Germany. So what values do they like to measure? And you see all these different aspects that you can measure with your smartphone, but we asked how many people do have a smartphone and how many people use their smartphone as well. So 90%, that's a good number. And I think this question is, we had about more than 250 questions here, but I have only like 5 for you in my speech here, and I think this is very important. Efficient medical care is more important to me than strict data protection. 65% of our citizens think this. So the next question is about the approval of the research data center, and there will be a research data center at ministry level, or there already is one, but it will be a wider. And they say that they think that such a research database in Germany is a nice thing to have, and we have more, we have 78% who said this is the way to go for Germany. So approval of the research data center. But we already, we asked who would you trust with health data, and they trust their physicians, but they will not trust their pharmaceutical industry. And they trust their researchers, but I think they don't know that we do research together with the pharmaceutical industry. That's the point. And that's the point about data health literacy. And just one question out of just one answer here out of the questions concerning health data literacy. And you can see here that they don't even know what we can do with our smartphone and with e-health applications. So just 12% think that our phone can see if we have a depression. So beside that, we have different platforms right now in Germany, and I want to show you one platform. That's the data donor app of our CDC. That's the Center of Disease Control, Robert Koch Institute, and they made a great effort together with the German Ministry of Health to collect data of smartwatches. I was a donor too, and we have here like one platform. The other platform, which is already there and which wants to collect data from insurance companies and other data from the EHR or registers and from perhaps from the Robert Koch Institute as well and from our DIGA vendors, is based at BfArM. That's our Food and Drug Administration here, and this is a secure processing environment, and they will provide tools and algorithms for researchers. So beside that, we made a huge survey on the maturity of our hospitals in Germany. This is the biggest maturity assessment in the world, with 1,900 hospitals, and we are very strong in structure, systems, data security, and reimbursement issues, and very poor when we want to reach out to our patients and with information exchange here. So let's look into the information exchange challenge. Right now we are doing a jump start towards international standards, and here you can see all the standards and standard organization and the umbrella organization, the Joint Initiative Council, and all these standards who provide on a worldwide expertise these healthcare standards. And you all know HL7, and HL7 is now providing the new FHIR standards. And we are also working together with the Global Alliance for Genomics and Health. And there will be a new platform in Germany for genomics. It's called Genome.de, and yeah, hopefully they come together and merge their knowledge. So the Interop Council is the new office for interoperability in digital health in Germany. And here you can see some faces that are here and within the advisory board of GIHF-AI as well. and we try to find ways to find the right standards and to find the right implementation guides. So coming back to our idea to have a survey which can measure and compare trust in health data usage in Israel and Germany. And this is the idea. We want to measure and compare the readiness of this approach within the Israel and German society. We will recruit about 2,000 participants. And the benefit is to compare and catalyze optimal further e-health adoption strategies and best practice in both countries. Thank you for listening. This could be one question. Like, oh, okay, that's too fast. Okay, are there any questions or advice for us, or, yeah.
So that's indeed a good question. If there are any questions from the auditorium to either Professor Thun or to Ran Balitzer, join us on stage.
I'll shoot first.
Go first.
So what do you guys expect to learn from this survey, and what do you think might surprise you?
I think that we have some pre-notions that will not necessarily be found to be correct. Our basic assessment is that in general sense, Israelis would be exceedingly open to any and all data use and would be not as worried about privacy aspects, while we will see a very different, maybe the stark contrast in the German basic sentiment. And I think that we will see that the answer is much more nuanced, that it all depends on the setting, sharing data with whom, for what purpose, and with what basic purview are we talking about. And I think it would be very different if will you trust with your data in Israel, for instance, will you trust with your data your HMO, or would you trust with that data the Ministry of Health, or will you trust with that data an industry company? You'll get three very different answers. We know, for instance, when we're not talking about health data, when we talk about how much are your trust, general trust in the HMOs and in national entities, ministries, for instance, the difference is dramatic in terms of your basic trust. I don't expect that the trust in terms of trusting us with the data would be much different. And so this could really drive some of the, I think, our understanding of what the public actually wants, and how much of the differences between Israel and Germany could be basically attributed to what the public actually wants, and how much is just conservative general approach.
So from the German perspective, Frau Professor Thun, what do you think, like, why are Germans so skeptical?
I think a big issue is the thing that there is not enough digital health literacy in Germany. We don't know what for we should use and collect data, and so that's the problem, that German people, they don't have the possibility to come closer to the doctor or to the insurance company to work with their data and to get advice from, for instance, our insurance companies who provide the EHRs. So they don't even know what to do with data and with health data, and this is a huge issue. But beside that, coming back to standardization, we have to talk about high quality data first, because if we right now work with that data that we have, this is just mainly free text, and we really cannot do research on this data or just work with this data. So this is the first step, to have an infrastructure which is secure and safe, and to have like data standards that we can use and share with each other and even with other countries.
So you spoke about conservatism and a misalignment of incentives. I'd like to understand maybe from each of your perspectives your top 3 recommendations to sort of overcome and align incentives and move the industry forward.
So I think one very helpful theme is showing the stakeholders what they can benefit from the full implementation. When it's abstract, there's very little willingness to participate. But if you are exceedingly concrete about what are the reaped benefits of the members of the public, for instance. In Israel, I think many of the people have some understanding or appreciation of what the data sharing gets them, what the research on data actually gets them. They are aware of the innovation taking place. They are aware of some of the abilities that they get, but maybe not to the extent that we should. So I think we should invest more in educating the public about some of the already existing benefits and some of the future benefits that will come further. So this is, if you asked for 3, I think this is one key thing. The second, it was mentioned before, we need to invest more in data quality. So right now, data is an output of the daily clinical work. Not everything that should be digitized is digitized. Too much data is lost. Whenever I have this vivid nightmare where I see ECG machines at Clalit being replaced, and I know everyone that's replaced harbors within it the data of thousands of patients, and from that point on, it's gone. So you need to salvage all this data, but it's not happening. So the new machines that you buy are already, connected and everything, but all of this old data that is now being scrapped, it's a nightmare. So we should make sure that all of the data is digital and is being properly collected, and there should be a well-funded quality improvement process of the data, which does not exist in almost any health organization that I know. Data is a byproduct of clinical work. There's no allocated funding for data assessment, data improvement, data quality assurance, none.
The same in Germany. Yes, and I think we have to teach our young students much more, and we try to have a curriculum for our students, and so that in all domains they have to include digital applications as well. So if you learn something about dermatology, they should show something what you can do with your app, and how you can share data with experts and AI algorithms and so on. And we have some institutes that are very, very good in Germany, like the Fraunhofer Institute and the Mewis Institute here, who work with AI on data. And beside that, we have to convince our people who are responsible for data security and safety in Germany to work with us and not against us. So I think this is a huge effort. And we have to work together with the media, with our journals and with all papers here, so that the public gets more knowledge of what we are doing here. Yeah.
So, okay, it's about educating the general public about the benefits, it's about quality, and also about accessibility of data. So 3 big items to take away, definitely, and I see that all the governmental officials and policymakers are taking notes, and we'll sure to also put it in our reports for this conference. Are there any other questions from the auditorium? This is your opportunity. Yes. Or a comment, also fine.
So, comment. I completed a research on Israelis and their attitudes towards sharing their data without their consent. It's a small study, nowhere close to what you did. Doesn't represent the Israeli public. 15% were healthcare workers, 11 to 12 were attorneys, another substantial part were people in the high-tech. Not representative. So asking them, do you think it's important to share health data? Yes, across the board. Does that justify sharing your data without consent? No. Healthcare professionals? No. Attorneys? No. Everybody else? No. Do you agree that hospitals will use your data for research without your consent? It goes up. So you are correct. It depends who uses your data. Not so much, but it goes up. Then we asked more, we gave them use cases. Okay, we told them, okay, your data is being used with an IRB approval, your privacy is being protected by a company to develop a device that will help diabetes. Now do you agree to sharing your data without consent? Yes. To the other side, not all of them, but very substantial. So my takeaway is not education, but transparency. In general, these are people that know about sharing data. I told you they're not representative. We had a small group of people there that had nothing to do, general public, that had nothing to do. I served them in an outpatient clinic. Same results in general. So my takeaway is a lot more transparency about what is being used with the data, how it's being used, how privacy is being protected. Not just saying it is all protected, but giving more.
Thank you very much. Anyone wants to comment on the comment?
I totally agree. This is very context dependent.
Okay. Well, I sometimes wish we would, not we, because probably we all share the same passion of what to do with our data and we would be willing to share our data. But looking at the general publication, I think it is about transparency, but it's also still about education, because no one cares from those billions of Facebook users what Facebook does with the data. And we're all happy to share our pictures and where we are and what we do, and no one's even thinking about it. And well, here at GIHF-AI we say data sharing is caring. So let's all care a little bit more and give the two speakers a great applause and thank you.
I'd now like to call up Esti Shelley and Dr. Suzanne Otsakowski for the roundtable. Who will be moderating, the founder and editor-in-chief about digital health.
Ready on the stage? So, it's time for a panel discussion after a very intensive day. So we welcome again on the stage Esti Shelley, Director of Digital Health from the Israel Ministry of Health, and Dr. Suzanne Otsakowski, Director General for Digitalization and Innovation from the Federal Ministry of Health, Germany. Maybe before I will ask the representatives of the tables, I have a question for you both. Dr. Otsakowski, you showed us at the beginning a beautiful picture of the parts of the car. And I was thinking about what parts do we already have in terms of AI, artificial intelligence? And the same question for Israel, of course.
Well, first of all, we have a lot of great researchers, and there is a lot of research going on also in terms of AI in Germany. I mentioned that we have around 38 research projects that we as a ministry are funding in terms of AI, but of course there's a lot more going on. I think so far we have one DIGA, for instance, which also uses AI. So there's a lot happening, but it's still, I would say, like small plants. And until it's a forest, I think we're still taking some time.
And what is the engine of this car?
I don't know if it's really one engine, because I think, I mean, like Ron was mentioning, the potential is so great, and I think that's seen by a lot of people, that there's really big potential, and so basically we just have to release people in order to translate their ideas into real practice. And so, like, the topic that's been in the room all the time, like data security, data protection laws, that's, for instance, one of the things where I think we have to open up things so people are able to realize their ideas and bring them into practice.
Thank you. Ms. Shelley, the same question, where we are in terms of artificial intelligence in healthcare in Israel.
So I think it's quite similar, but some aspects are different. We do have good research in the universities that are happening. I think one of the benefits that we have here in Israel is that we have some strong industry, specifically in health, that is working on developing AI-based algorithms and tools. And I don't know if to say it if we are luckily or not, or should be worried, but we have some AI algorithms that are already implemented and in use in healthcare organizations in Israel. Now, I'm saying it with a question mark at the end, because we don't necessarily have the risk management scheme in place, which we should have by that time. Definitely when we are talking about some of those algorithms that are being used in practice. So I think we are quite advanced on those topics. We do see also some examples of implementation of AI-based technologies in healthcare facilities. We have some examples in medical imaging that are being implemented for prioritization of medical imaging. And some other examples. So I think we have some parts of the car already in place, but I wouldn't say it's safe to drive yet.
Thank you very much. Before lunch, we had workshops, and now I introduce the representatives of different tables, and I ask Dr. Anke Diel, who is a Chief Transformation Officer at the University of Medicine Essen, to come onto the stage. Dr. Anke Diel, please join us. Ian Sanders, who will represent the startup table, he is a CEO of Blue Cape. And from the policy table, please join us Ronja Rubinstein, who is a co-CEO of COMS, and Nicole Formica-Schiller, CEO and founder of Pamanico. So we have two representatives of policy. I think so. Policy is very important, yeah, when it comes to AI. Yeah, and hard topic. I have to say, I was participating in the policy table, and the discussion was very lively. So maybe before we jump into the discussion, I will ask the representatives of the tables to summarize the outcomes and the results. Who would like to start? Maybe policy.
Okay. So thanks a lot already for a very amazing conference, first of all, for every great input which we have heard during the day. So very much appreciated, and I think we already all contribute a lot to the transformation in digital health. Having said that, we had a very, very interesting, lively, productive, and overwhelming discussion with a lot of sometimes controversially discussed points, but I always like controversial discussions because that actually pushes innovation from my understanding. And we came to a lot of conclusions, which we will dive in later, and which Ronja will also comment on that. And we also made an outlook, which I find also very important for 2023, and we will touch that topic also later, topics we would like to address and getting addressed by GIHF-AI.
So if we dive into right, into the topics that we discussed. So one of the topics that came from wanting to use data was data silos and the problems of addressing data silos. And from what we saw, that it's not enough to have a policy that says we want data to be used, we want collaborations around data. We do need to see more of a drill down into what it takes to share data. What are the incentives? The reasons that the different data holders want to share data, when do they want to share data, what are their obstacles into sharing data, whether it's the cost of sharing data or other relevant interests that they have to be addressed in order to facilitate this sharing of data, because if it doesn't, just mandating, let's share data, that won't do. We need to really drill down into further how it happens. We looked at the European EDHS and said it's a good idea to have these centers for sharing data. But again, the question is not only the policy, but how will it be implemented, and will these centers be something that would be useful and user-friendly? And the Israeli experience is telling and not telling at the same time. So in Israel, we have a lot of competition between the different data holders, and that makes the different data holders very good because of the competition. So having competition is good, and I don't know how the European and German legislation can encourage that competition. On the other hand, when you have competition, you have less collaboration. So we need to find the fine road, right, about how to balance having the competition, which is good. And again, it goes back to what I said before about the different data holders getting what they need and their interests, right, in the data, because then they have the incentives, and then they want to be friendly in using, et cetera, et cetera. So it comes back to the same sort of issue. And we also looked at the roles of the Ministry of Health as continually surveying what happens with the regulation that comes out, what is really happening out there, and how can it be quickly addressed, an amendment and changed, so that it's not only a law that was passed, and now that's what we are looking at 20 years down the line, and this is how we're acting. Because as we have seen in the last years, we keep having new challenges. And we will 100% have new challenges coming up next month. So there should be the surveillance on the one hand and the flexibility on the part of the regulators to amend regulation, to fine-tune it, to simplify it, to make it more user-friendly. So that data is being used while, conserving all the values that need to be conserved. Preserved? Conserved?
So let's proceed to startup table. What was the key topic at this table? What are the results and conclusions for 2023?
So results are iffy at best. Well, we definitely need a lot to improve on. So I want to break it up, and in a summarization of, I would like to call it the difficulty for even an early stage startup like myself to break into the German market, and why, unfortunately, at the current status, we personally would most likely go first for the US market. So before us personally, I'll go more into general what we talked about. So first and foremost, a lot of companies, not only Israelis, I would say Americans or British, something that apparently we don't realize is that Germans in general, you're quite different. So Germany from Berlin will be completely and totally different from a German from Cologne, and a German from Cologne will not be the same thing as a German from Leipzig. And it's I apologize if I mispronounced that. But in general, kind of to prepare the startups to go into the market. Because yet again, when you're marketing, when you're trying to target specific groups or populations, it's very important that you understand the certain sub-trends that drive those populations. And I think that's true for any startup, both dealing in consumer products, healthcare, it doesn't matter. In the end of the day, we all need to understand those issues. The second general issue was difficulty when it came from the legal perspective. So I'll actually go into something which now I'm actually thinking of a hypothetical solution to it. But apparently there's, beyond, let's say I'm working now on AWS Cloud, for example. I'm working through cloud. So there could be certain pedigrees or certain degrees of acceptability that would be okay with AWS, but would not be accepted by, let's say, the German Ministry of Health or working in Germany in general. And therefore, it would stop me from working in Germany or maybe then going over to a different market. Third thing, which I think is also quite an issue as well, we talked, very specific point was on German physicians or in general the healthcare system not adopting innovation fast enough. And I'll actually come this from a perspective. So an issue which I don't actually remember exactly who talked about it, but in general in our movement from handwritten, moving into classical EHRs, EMRs, so we can digitalize these processes and we can really garner that data, you're seeing apparently difficulty from the actual physicians themselves, that they do not want to make that switch. Now, taking this solution, which may exist hypothetically more from network theory, when it comes to penetrating a market to gain critical mass, you wouldn't target the entire population. When you want to gain critical mass of a population to use a given platform, to use a given system, you don't need 100%. You need 10 to 15% of the first adopters to use the platform, and then you can obtain critical mass very, very quickly. This is called a networking effect. So maybe an idea that we hypothetically have, find key people, German physicians or key people in the German healthcare system to adopt these innovations very quickly, let them build a critical mass, and then afterwards we can then drive this throughout the entire system. And I would say finally, conclusions. As a small startup that's hoping to expand very rapidly in the near-term future, I would very much like to bring our technology and our solution to the German, German people and Germany in general. And very much hope that we can all work together in order to really better patient outcomes. That's the main goal in the end of the day.
That's a very positive message to the audience. Let's jump now to the research table. Dr. Odile, what happened at the research table?
Well, actually, when I listened to what the summaries of these other two tables were, I think one of the things that really pushed us all is also looking into policy and regulatory affairs, So it was actually the same for the research table. We focused on three areas. The first one was we discussed infrastructure. Infrastructure for the usage of health data sets for research. And in Germany, you find that especially at the university hospitals, through projects like the Medical Informatics Initiative, there are data integration centers that are being built up. And on top of that, we also have widespread usage and emerging very good platforms that the university hospitals themselves actually build up, But that leads me to the main problem is that we do have a very sectoral medical care system, and there are no health data sets from the other medical sectors, and we don't have an EID or master patient index, so we can't even, if we would, be able to have access to these other data sets, we can't link them up on a personalized level. And that brings me to the regulatory issues. The linkage itself is legally unclear, and there's a lot of work happening with respect to that, to upcoming laws next year. There is a particular problem in Germany with the federal states because they all have their own data protection laws, and that means that it's very difficult to pass laws on usage of cloud or, also other data protection things on a national level. When it comes to Israel, we heard a lot by Ran, about the HMOs. So that means that there's actually a widespread use of anonymized data. He told us that there's even like an automatic push of demographic data sets that are being integrated. So in real time, you can actually use these data sets. but you can only use non-anonymized data sets for individual patient use. And there's a law in Israel, apparently, that also allows a fairly good use for secondary data use. So the second point we focused on was how can health data sets actually be used with respect to the FAIR principles of findable, accessible, interoperable, and reusable. And for both countries, we said, well, standardization and interoperability is still the main challenge for both. There are easier things, like in Israel. There are only a few hospital information system vendors, whereas in Germany we have about 250, because we also use, of course, all the other international and European ones. We talked about consent, and that is something that you also picked up in your comment. And yeah, the last thing was how can you actually establish, a better sharing of health data sets. And we agreed it's good, to have pilots, like, for instance, the Charité, as Sylvia told us, and also we in Essen, we've got agreements with Sheba, Innovation Arc. So those are kind of pilot projects. And we also discussed that, of course, instead of, sharing data sets, one can also go with respect to AI, the detour, and take federated learning and have the algorithms actually travel. But the main problem, which is universal, is that there is no international standard and no joint data sets.
Okay, so we have three perspectives. The first perspective, policy table, data silos. It's not enough to have policy in place. We need more. Then we have startup table, healthcare system is not adopting innovation fast enough. Then we have research. And we need to invest in infrastructure. We need to invest in interoperability. And then I ask the policymakers, of course, how do we implement all these changes that we've heard?
I blink.
I copy.
Yeah. Wow, I wish there was a very good and short answer to that. That would be make our life much easier than what it really is. I think there are no shortcuts on some of the topics that were mentioned here. I think first, standardization and interoperability and all the issues that are talking about data quality are still important, and also it's a long way to go. No one thinks that this is something that will happen like in a 1 year time, but this is something that, at least in Israel, we have started to walk toward this way. And I think the role of government is still to hold the resources and the capacity building in order to keep walking this way for a long term. But again, this is only one part of the discussion. I think the fact that we still need to have legislation in place allowing the use of data, and specifically the use of health data for research, but also for primary use, and trying to, the word that comes to my mind, to break the silos, but it's not, in saying break the silos, it sounds like very destructive, and this is not the aim to be destructive, but to create network of that enable collaborations. And I think one suggestion that I will give Susan to comment maybe is how, when we are working so closely of two countries together, maybe we can start to draw like bridges between the two countries that maybe just an example of that you gave of the Charité with Sheba or Charité with Clalit, to say, okay, now we can have this specific bridge, we can allow it, we can make sure that it will continue, and maybe we can learn from this one and to see how we can elaborate further on. But this is something that I think can happen today when we have this kind of collaboration and trust between the ministries. So, Thanks. Yeah, maybe to pick the last point up, actually that was a very concrete thing that we discussed because I was taking part in the workshop on the research questions, and actually what really struck me in the workshop was that, yes, we're talking about standardization of data, and that is of course very important, but I think another aspect would be to standardize laws in terms of, at least within Germany, in terms of, for instance, data protection, because actually RAN was asking a couple of questions in terms of, can you do this in Germany? And then there was like, yeah, either there was silence in the room because everyone was like, not sure, maybe if this and that condition and so on, or there were two people saying and one yes and the other no, and then so it was very clear that apparently this is also a point that it's often not clear whether something is possible, and actually this is something that we hear also at the ministry basically every day, because there are people approaching us and saying, look, it took us 2 years, 3 years in order to get this or that going, simply because we had to ask 50,000 different authorities and everyone gave us different advice. So I think this is definitely something that we really have to work on to only get the first step in terms of making research possible within Germany. But of course, it should also be possible to go across the national border. Maybe to pick up some of the points that you were mentioning in terms of the startup table. Of course, the angle that we're looking at these topics from the Ministry of Health is always a little different, because we're not looking at it in terms of how can we make it, or how can we create the easiest way for startups into the healthcare system, but we are looking at it in terms of how can we create the best outcome for patients, or how can we make the healthcare system better in terms of more efficiency. And then, of course, one solution to that could be DIGAs and the products that startups provide. So I think when you take that into account, of course, you will see why do you experience maybe some of the barriers that you see as barriers, but we find important simply because we only want those products to be reimbursed where we know and where we see from studies that they have a real effect. But of course, we are also aware that, well, it's not easy. We can see in terms of numbers also that the DIGAs are not something where today they have or they're creating a huge major impact on healthcare as it is today.
So what I would say is I 100% agree with you from a cost analysis perspective. We obviously view this completely and totally differently. I'm viewing this simply that in the end of the day, I need to return ROI to my investors, and therefore I'm obviously looking, not only to improve patient outcomes throughout Germany or any other nation that I market in, but just in general, it feels that from our perspective, just like you stated before, we have to go through 50,000 different organizations, and there's quite a bit of bureaucracy. It makes it very off-putting, because in the end of the day, I'm not entitled to myself. I'm entitled to our investors, and it's my fiduciary responsibility to ensure that when I go into a market or I take us into a market, that we can succeed, thrive, grow, and move forward into that market. So of course I understand your guys' perspective. I'm just saying it simply from our perspective. I think that's the most important thing at all, instead of not viewing this as an adversarial perspective, as it's the health ministry against the start. No, of course, that's what I'm saying. We all are here to work together in synergy to improve patient outcomes, to improve health, whether that be in Germany, the United States, or in Israel. And I think when we can all come together on that same goal, really great things can happen.
Please, can I just quickly comment on that? Because,
absolutely.
I mean, one of the things that I very often lack is the user orientation. And with the user orientation, I don't only mean patient orientation, because that is, of course, prime success. But I'm a medical doctor, right? And also my user orientation very often is kind of, not really important for that. Like, for instance, I'd love to have exactly those data sets that we've got in the DIGAs back in the hospital information system or in the private practice. And you don't have that. You only get a PDF back, and then I have to open that again, and I have to read it, and and I can't use those data sets. And technically, this is possible, and it would be so important for the patient. And again, the patient kind of doesn't understand, and he says, well, but it's all in the system. Why don't you have it? I mean, you prescribed it as a doctor, and we don't have it.
I agree, it's a shame.
I would like to ask you about some controversial issues, because at the policy table, I realized that one of the most controversial issues that is dividing the public there was GDPR, for example, ethical rules for data processing. So now the question to each of the table representative: what was the most, maybe not controversial, but an issue that was dividing the representatives from Germany and from Israel? I'm asking about this because we want to find a common place, a shared point. Maybe that's the beginning of looking for a solution that we will find and then we will implement.
Well, I have to disappoint you a little bit, because we discussed controversially, but not so much, and this was also a little bit to my surprise, that we had points where we said, okay, this is completely the German perspective and this is the Israeli perspective. One point which has several times and actually touched by each of us is the topic about the GDPR. And this is really an issue in Germany. So we had at our table representatives also from the ministries, but also from academia. And this is a big topic, and I think this is a bit of a difference between Germany and Israel, because in Germany we have many federal states, and as a startup or also in academia, when you want to get data or when you work with data, in worst case, you have to, depending on where you want to get it, you have to approach so many representatives in each federal state, and you have to wait, and you have to get feedback, and in worst case, to get feedback from so many different feedbacks. And I also represent the German startup scene with regard to AI. For many of them, that's a big, big struggle. And with regard to that, I always used to say, and I said it also at the policy table today, and it's a bit of a provocative statement in Germany, I say the GDPR should not be used as a hindering point for innovation. Because I always hear when in Germany, like, we have the GDPR, and the GDPR we have everywhere kind of in Europe. And we see countries, we have to be also frankly honest to us in Germany, like in Denmark, for example. They also handle the GDPR in a quite innovative way. And the GDPR is, in general, a very good thing. It's for protection, and it's a good approach. But we should make it, and I think this is a little bit the innovative spirit, which is very good and positive in Israel, not see it like as an obstacle, but actually as something which can make life theoretically easier, and therefore we have to move a little bit away from bureaucratic issues. And we also have to see, and this is the point with the policy topic we also discussed, we discussed mainly the EHDS, European Health Data Space, and the upcoming EU AI regulation. So the outcome with regard to that was also any regulation, any upcoming regulation, should not be seen as we now release this regulation and now it's fixed for the next 5, next 10 years whatsoever, because technology, artificial intelligence, but everything else develops. And therefore we need some specific kind of freedom that the regulation also adapts to the innovation. And why I'm saying that last point, because we see at the moment occasionally already discussions with the GDPR that in certain parts it has to be revised. And this is not bad, but it's also not completely good. It's the mindset that when we go out with the regulation that we are already aware we need to adjust it. And I think that was a common agreement and alignment we had in our workshop between Israel and Germany. And I think this is a very good basis to build on.
So one thing I can add, just to what Nicole said, which is absolutely correct. I think the values between Israel and Germany in terms of the health system are very similar. We have very similar health systems in the terms of solidarity and universal. And privacy in Israel is respected in essence just as much as it is in Germany. But what the Ministry of Health in Israel did in 2018 is it gave us guidelines. And those guidelines were like a decision tree that helped us take the value of privacy and implement it on a specific data sharing project. So how do we look at the risk in the privacy? How do we, what are different measures that we can take around it? You know, how do we treat it? In just saying, because we can say about any data sharing, oh, there's risk of privacy. Always there's a risk of privacy. We can do nothing, no problem. We would always be right. And no innovation and the things that we can benefit from healthcare and AI and digital would never materialize. And I think this is something that a regulator can do, the same as the Israeli regulator did. And especially if it's something that is relevant for a large, many institutions, then it can help harmonize the way that it is being treated. And then you can expect similar, maybe differences, but similar ways of looking at things. Whether you go to, in Israel, whether you go to Clalit, or whether you go to Rambam, or whether you look at things in a bit of a similar way, because we have some sort of guidance that we all read, we all look at, we all analyze in a very similar way. So you have a conversation, a language to take it down from the law and whatever it says to how do I do this specific project.
So something in particular, I do agree 100%. We need to have regulation. GDPR is critical. It is important that privacy of patients is maintained, whether the HIPAA, GDPR, irregardless. I'm not here all for deregulation, like what has happened, if any of you follow crypto, FTX and and Sam Bankman-Fried, who is a fraud. Not here for anything like that whatsoever. But what I am here to say is that we need to incentivize companies that will pay by the guidelines. We need to make it easy for them in order to innovate. Because together, with companies that will innovate based on the guidelines, and together with, whether that be the Israeli government or the German government or the US government, we can really create great things.
If I may comment on the regulation part?
Yes, sure.
I'm not sure how great was the 2018 guidelines, although we are proud on them and still keep them alive and valid. But I would say that I think sometimes, even in our ministry, we sometimes get confused between regulation, which actually mean risk management, to regulation, which means I'm trying to micromanagement of what's happening somewhere else in the healthcare system or in the industry or whatever. And I think the fact that both countries agree that need to revise the regulations, whatever regulation, whether it's GDPR or something else, that means that the regulation is not really filling its, let's say, its duty of really managing the risks. Because if it gives the tools to manage the risk for the people that need to comply to the regulations, then it's supposed, and I'm saying it theoretically, but it's supposed to meet the technology that developed while we are moving ahead. And I think also remember that the regulator role is not just stating the regulations, but also trying to promote how the different stakeholders will be able to comply with the regulations. In Israel, for example, we have done twice, in 2018 and in last year once again, incentive program for the healthcare organizations in order to support them in developing the infrastructure for research on data. Because understanding that Clalit, in the end of the day, just naming Ran here, is a healthcare organization. It's supposed to take care of patients. It's not supposed to give services to startups. That's not their main business. That's not what they're supposed to do in the morning. And that's not what they're supposed to do with the first free dollar that they have. So how we can bring them the incentive and some government support in order for them to be able to handle the data securely and to do the research on the data.
I think it's time for questions from the audience. Are there some questions or comments?
Thank you.
Now I can see. So I have a question, of course. I have many more questions. I have a feeling that this discussion would be much more easier if we have had a trust from the society, from the citizens, from patients. If they would expect that, you know, we have innovations in place, that we have AI in healthcare, that we have new technologies, then we, as policymakers, decision makers, would be forced to make these changes. So the question is how to gain trust from the society, from citizens, from patients, because we are talking about this all the time, but I'm missing a recipe as something concrete.
So first of all, and as I said, I can just comment, I want to just comment on the German market. So first of all, with regard to the trust, of course we have to differ when we say trust is a trust of the population in AI applications or trust in digital health. We always have seen in the last years very motivating actually surveys like from Bitkom, one of the biggest industry associations, where people actually say they have a huge trust in digital health. They also have actually quite a huge trust in AI in healthcare. Of course, and we all know it's always the question how the question for such a survey is raised and asked. There was the other way around the question, would you rather have a GP sitting opposite you or like an AI? I mean, this is already, we know, a bit of a special question. Of course, then they went for the human being. But in general, what I want to say is the general approach in Germany for digital health, for AI, is very good of the population. They just wait for the solutions, that they go to their GP, even also not just in the big city centers, but in the countryside, and he can offer that. Another big thing, and this is, I think, also a very good conclusion or thing we heard here today, and I was surprised that it popped out so many times, was the word, we can reword it, education. So we can create trust, in particular, for outside the industry or seeing people in artificial intelligence by creating a knowledge about what is AI. It's not the bad thing, it can help you. And this trust we can create by, I don't want to say it educating, but showcasing, in particular when it comes to health, what is the benefit for you? Because health concerns us all, and it's one of the most important things. So you have to showcase the people, this is a positive outcome for you if this is used in with a digital tool, with a digital application, with AI. And then the people, I think, they're responsible enough to say, this makes sense, you know, and this is good. And then we can create trust. It's not that every citizen out there needs to understand machine learning or whatsoever into every detail.
So I'll have to be a little bit annoying and remind us what we all know, right? That trust is fundamental to healthcare. And privacy is fundamental to healthcare. And without these things, we don't have healthcare. Because if a person comes to their doctor and they cannot say, I am suffering from X, and I am so-and-so, and this is my personal circumstances that affect my illness, we do not have a healthcare system. So whatever the benefits are, if we undermine this really basic truth about healthcare, we didn't reap real benefits. So that's why this conversation is always ongoing, and that's why we're always, you know, feeling that we're running around in circles. But it's true. This is something that we cannot say. And one of the things about healthcare that it's fundamental, right? It's part of healthcare. It's not something from outside. It's inherent.
But it's not a contradiction, I find, you know, because, I mean, before MRI scanners were invented, you couldn't use them as a diagnostic tool. Now, before AI algorithms were not invented, you couldn't use them as a diagnostic tool. But if you have medical evidence that it improves your diagnostic, me as a doctor, I'm obliged to use these things. So it's more like a clinical decision support, you know, scenario, and an automized analytical tool.
What I would say in particular is trust is something which is very hard to build and can be torn down very, very quickly. And that's why I think, especially in healthcare in particular, it's very critical that we are as open as possible. Just like when we look at, let's say, you're looking in DevOps or in crypto, you're looking at open source algorithms where we're showing the public exactly what we're doing hypothetically, we need to be as open as possible to the public of how our healthcare systems are working. Because the minute that that trust is broken with any population, it doesn't matter, it's over. They will not listen to you again. And it's very important we build that trust and keep it.
Maybe adding on to that, and I completely agree, trust is an absolute must, but it's not sufficient in itself. And where I wouldn't agree is that the patients are basically the main lever in order to bring AI into healthcare, because I think the idea that there will be a patient coming up to his doctor and saying, hey, I want you to use AI, I think you can probably count them on one hand. So I think I think the major driver have to be the doctors, because I mean, usually most people become a doctor because they want to provide healthcare to patients, they want to make people healthy. And I think this is something, like this motivation is something that you can work with really well by showing, okay, if you use this or that, like decision support, for instance, this will make you a better doctor. And I think that's really the main narrative, how we make use of AI in medical practice.
Something which I would just like to say, and I actually completely agree with you, there are a lot of startups and there's a lot of products that are being built that literally do not serve the purpose of the patient or a certain organization. And a product that doesn't serve a purpose is like a person who doesn't have a purpose in life in the end of the day. When we build a product, we build it to serve a certain population. And that's it.
We have to slowly finish the discussion, but before I would like to ask you, each of you, to tell me what's the priority for 2023 in terms of innovation in healthcare and also artificial intelligence in healthcare.
One priority.
Yes, one. Or two, yeah.
There's several, yeah, okay. One is definitely getting our health data lab started, because this will be the one center where we are able to get hands on the data for research purposes. Two is bringing our EHR from theory into practice and preparing also the legislative process for that. Three is publishing our digital strategy, which will hopefully give us a lighthouse of where do we actually want to go, how do we set the right priorities. And I think if we can make a check mark at each of them at the end of the year, I think we've had quite a step ahead.
Okay, thanks. Wow, it's difficult to choose one, but so I will choose three. So 3 out of I think around 10. But I think in Israel now, for the coming year, we have the legislation regarding data sharing and data portability, which is a major one that we wish to pass in the coming months. The second thing is that we are establishing a regulatory sandbox in order to understand better how we can adjust regulations in order to try different digital health technologies in practice and to see which ones become the game changers of the healthcare system. And the third one is to see how we are moving forward with AI regulation, which is a major challenge because we don't want to hold the system, the healthcare system and the industry, but we would like to make it, let's say, more fit to the risks that we are seeing.
Interoperability, no? In order to improve user orientation for both the healthcare professionals and, of course, the patient.
So I'll come at this more from a, I would like to call it a deep learning perspective, I would like to say. So there's actually now quite a bit of work being done on graph neural networks, specifically when it actually comes to trying to analyze patient outcomes. There's some research papers that have been done on that, a little experimental. Interesting stuff, anyone who wants to look into that.
So we also had adaptive AI, that is another challenge that we will be facing.
Data economy was a big one, which we actually just started discussing at the end, so we can talk about that then the next time. There's a lot to discuss.
Okay, thank you very much for a great discussion. A big applause for all the panelists.
Wow, okay, what an amazing concluding panel discussion. Thank you very much, Arthur Olesch, for moderating this, and all the panelists, the representatives from the 3 roundtables, and the 2 representatives from the ministries. Thank you very much for joining us here up on stage. So we are almost done, and now it's our challenging job to conclude the day. So, Risa, what have we learned? What are you taking with you from this conference?
Well, my head is still spinning, but we covered a lot of topics today. We covered data infrastructure and regulation. We covered trust and transparency and quality data and health literacy. For me, it was really interesting to see 2 different countries' perspectives with a common goal. We all care about patient outcomes and improving them. And to steal Ron's quote, moving from patient-level reactive therapeutics to predictive care, or rather from sick care to health care. And I think that shared goal is fascinating when we both approach it from two different perspectives. I, for one, leave optimistic. I'm going to circle back to Suzanne's mountain climbing analogy. But given the thought leaders in the room and the lectures that we heard today, I think we're headed in the right direction.
Well, very well. I mean, not much that I could add to that. As we all learned also today, trust is key. So, and we learned just, again, also here at the concluding panel, that trust takes long to be built, but can be ruined very, very easily with just one wrong decision, or maybe a lack of transparency, or maybe just the unperfect legal framework. So there is a lot to do in the upcoming years to come. For sure, GIHF-AI will continue to contribute to the political debate, will continue to bring together policymakers, governmental officials, experts from academia, from business. We could easily say, building on a Jewish phrase, and next year in Berlin. So, but for sure we won't see each other just in a year, but much earlier before on our round tables. We picked up on, I think it was on the startup roundtable, on an idea to also implement groups on our LinkedIn website. So every one of you is probably on LinkedIn. You all know the GIHF-AI site on LinkedIn, and you use it like our website, where you can find all the briefings, all the reports with the recommendations, and many more. But we will also try to implement some kind of debating rooms inside this LinkedIn page, so that we can all follow up after this conference and that we can continue the discussions. Another opportunity to continue for sure is the Health IL event tomorrow. So with your badge, don't lose it. You should have all access to the main event by tomorrow. Well, I'm supposed to announce that there is a bus for the German delegation waiting outside. Okay, so don't miss that either. We will have the videos of the whole conference on YouTube, so if you would like to review anything or share it on social media, don't forget the hashtag GIHF-AI22. And I think last but not least, I'd like to call all the participants here in the conference from the 2 ministries of health, from Health IL, and for sure the whole ELNET team from Germany and Israel on stage, and all of them who have been working behind the scenes for weeks, if not months, on this conference. In particular, Lea Ledvon as a program manager, and all the other colleagues in the ELNET office here, and so here in Israel and back home in Germany. They deserve a very, very big applause for that. So please join us here on stage. And yes. Yes, you may continue. So just again, for everyone to see the faces behind this conference, the brains and the hands. So thank you very much for all the great collaboration. Aline, Joel, and then our team. There we go. Leah, Geno, Jill, and Hannah. So that's the team, and they deserve this applause.
Congratulations.
Very well. I think it's over, isn't it?
Thank you to everybody, and we'll see you tomorrow.
See you tomorrow.